Welcome to our second day of our Myasthenia Gravis Education Conference. This is a two-day conference with Friday dedicated to health professionals from all specialties and allied health professionals as well. Welcome to them. And Saturday has historically been dedicated to all our patients and their family members and caregivers. And so we had a great time yesterday, and we have Dr. Schroff, Dr. Anderson, and myself, and Dr. Cow, who will return today and discuss a number of topics. So this is Saturday's agenda. After my introduction, Dr. Schroff will come and give an overview of myasthenia gravis. Dr. Cow, pulmonologist from Stanford, will connect virtually. And then after a break where you can visit our virtual hall, Dr. Anderson will talk about the management of what we call exacerbations in crisis. Dr. Schroff will return to talk about practical approach to when you come to the ER, how to navigate, how to advocate for yourself. And then I'll finalize this to talk about current therapies and treatments. And we hope to have a discussion, if necessary, to cover COVID vaccinations and what's going on currently in our world. Just some housekeeping items. All financial disclosures of our speakers have been submitted. However, if you find that at any point in this symposium there's any bias, promotional bias for drugs or medicines or anything beyond what's expected, please let us know immediately. You also have a link to Poll Everywhere that you've been sent. We really want your questions, so as we're speaking, please don't hesitate to submit your questions as we go. We have it downloaded. We'll be able to answer them in real time for you, so we welcome those questions. I also would like to, these are our speakers, I'd like to go ahead and acknowledge our vendors who are in the virtual hall. I invite you all to enter the virtual hall during the scheduled break. And our sponsors include Alexion, Arginex, Horizon Therapeutics, Janssen, and UCB, as well as we'd like to go ahead and acknowledge the Myasthenia Gravis Foundation of America, its leadership under Nancy Law, as well as Dove 11, and our HMH CME staff. So, without further ado, I'd like to introduce our first speaker. Dr. Sheetal Schroff actually was trained in Texas, Galveston, and she actually joined and did a fellowship with us several years ago and has been a partner in terms of the care of neuromuscular patients, clinical trials in myasthenia gravis, and as well as the Electro diagnostic tests that we do. And so she's going to give a very good overview on myasthenia gravis. Dr. Schroff?
Thank you, Dr. Green. Okay. So today, my lecture is about myasthenia gravis overview. So these are my disclosures. So there will be some repetition of slides if there are in the audience who have attended yesterday also, and some are new as well. So I'm going to cover the historical perspective of myasthenia gravis, epidemiology, pathophysiology, clinical features, diagnostic studies, and management as well. So the very first case of myasthenia gravis was mentioned in historical chronicles from Virginia on Chief Opencacanow, where it was quoted as the excessive fatigue he encountered wrecked his constitution, his flesh became macerated, the sinews lost their tone and elasticity as his eyelids were so heavy that he could not see unless they were lifted up by his attendants. He was unable to walk, but his spirit rising above the ruins of his body, directed from the litter on which he was carried by his Indians. So this was in 1664. Later in 1672, Thomas Willis, in his book De Anime Brutorum, meaning function of brain, mentioned a possibility of a circulating substance called explosive copula, and fluctuation in its level in the blood could be causing the varying weakness as he observed in his patients, and he termed it as spurious palsy. In 1877, Sir Samuel Wilkes described a case of bulbar paralysis, fatal, but no disease was found. So this was a case of bulbar paralysis, meaning speech, swallowing, respiration, breathing problem, whose weakness fluctuated but then ended in death. Autopsy was done, and then both grossly, they looked at the brain and then the brainstem area where it controls really all the swallowing, the speech, and the breathing muscles, as well as microscopic examination did not show any change in the tissue. So they didn't know what was the cause of the disease. In 1879, Wilhelm Erb described 3 cases of myasthenia gravis in the first paper dealing entirely with this disease. He drew attention to some of the clinical symptoms like droopy eyes, double vision, swallowing problem, facial weakness, and weakness of the neck muscles. And he also mentioned about relapses and remissions, meaning flare-ups, were also described. In 1895, Frederick Jolly, in a meeting in Berlin Society, he gave the term myasthenia gravis pseudoparalytica. Myasthenia in Greek meaning muscle and weakness, gravis in Latin meaning heavy and grievous. Later in 1934, they called it as the miracle at the St. Alphegis, where Dr. Mary Walker had a patient with myasthenia gravis, and one of the visiting neurologists, Dr. Brown, explained that this patient looked similar to the patients with curare poisoning. So at that time, the treatment for curare poisoning was physostigmine. So Dr. Walker tried physostigmine in her patient with myasthenia gravis and noticed remarkable improvement in the weakness. So really, I think 1934 is probably when the very first treatment of myasthenia gravis with physostigmine came into existence. Then the first thymectomy in a patient with myasthenia gravis was performed in Zurich in 1911. Later on in 1937, Blaylock reported improvement in myasthenic patients after thymectomy. So what is myasthenia gravis? It is an autoimmune disease, meaning your immune system attacks on certain areas of the nerve and the muscle junction, causing myasthenia gravis. It manifests as muscle weakness, which worsens with repeated use of the muscle or muscle activity. Patients are usually best in the morning, and then later on by the end of the day, they fatigue, tire out, and weakness gets worse. Epidemiology, incidence is about 20 in 100,000 population in US. 10% of these patients have only ocular symptoms. That means only eye symptoms. There is bimodal peak, that meaning the first peak is in third decade, in around like 30 years of age, more so in female population. And the second peak is between 60 to 70 years of age, and this is more so in male population. Females are more, slightly more affected, or the incidence in females is higher compared to males before the age of 40. At puberty and between the age of 40 to 50 years, both male and female have equal incidence. After 50 years of age, males are predominantly affected, and more so in European population. There is juvenile MG as well, which is seen more so in Japan and China, and here children less than 8 years of age are predominantly affected. They have also seen that MG is more prevalent at the equatorial region, and it decreases as one moves away from the equator, which again tells us that there might be some environmental factors as well playing a role in development of MG. Certain risk factors are predisposing genes, environment, sex hormones, infection. All of these can contribute to development of MG. So this is a normal neuromuscular junction. It's a pretty busy slide. Basically, when the nerve impulse comes to the nerve terminal, this is the nerve and this is the muscle, there is release of a chemical substance called acetylcholine, and then it attaches on the muscle to these receptors, and then the muscle contracts or the muscle moves. This is a simplified version of a neuromuscular junction. As you can see, there are a lot of different proteins and structures involved in this neuromuscular junction, which is required to function properly for muscle to contract and work normally. So any abnormality in these can result in myasthenia gravis. So these are all the known antibodies in myasthenia gravis. We know the antibody to acetylcholine receptor. We have the MuSK antibody, LRP4. And then there are others like titin, ryanodin, and still there are so many other different proteins here which we don't know if there are antibodies developing against them, how it would affect. And that's where seronegative MG patients, come into picture, who are negative for all the antibodies but still have symptoms of MG. Now, function of thymus. What does thymus do? So it's a T cell educator, meaning your own T cells should not be attacking your own body. It's mainly meant to attack foreign substance, whether it's bacteria, virus, and things like that. So whenever a T cell recognizes your own body's protein, or like say for example, like acetylcholine receptor, as a foreign protein and tries to attack it, the thymus doesn't let it go into circulation. It kind of eliminates or kills that T cell within the thymus itself. But some of these T cells, they escape the thymus and then they enter into the circulation, and there are certain checks even in the peripheral circulation. And then when those T cells which escape into peripheral circulation, they get as well eliminated or destroyed. So this, these are the normal T cells. They pass and enter into the circulation. And then these are the dysfunctional or the self-reactive T cells. Either they undergo clearance within the thymus, or the ones who escape into circulation, they undergo clearance in the circulation as well. But in MG, thymus is dysfunctional, so it's not working normally. So either it doesn't clear it right away, or even the checks or the police in the peripheral circulation, they don't clear those autoreactive T cells as well. So what happens is, these are the normal cells, they go through it, and then these abnormal self-reactive T cells also go through the thymus. And then when they reach the peripheral circulation, they don't get cleared here either, and then they start making antibodies, and then it can result in MG or autoimmunity. So in about 80% of patients with acetylcholine receptor antibody positive MG, they can have enlarged thymus. In about 10 to 15% of late onset MG patients can have thymoma. MuSK MG patients, they don't have thymus involvement at all. So some of the clinical features include eyes or ocular manifestation. 50 to 80% of MG patients initially present either with droopy eyes or double vision. And in these patients who present only with eye symptoms, they can generalize or develop generalized MG within the first 2 to 3 years. It can also present with fatigue and muscle weakness, more so in the proximal muscles of arms and thighs, face as well, and then it can cause neck muscle weakness and result in head drop. Speech can be involved, resulting in slurred speech and nasal intonation, swallowing with choking and nasal regurgitation of fluids, shortness of breath if there is respiratory muscle weakness. Worsening of myasthenia, so it can present as exacerbation or crisis. So there is a difference between exacerbation and crisis. So in exacerbation, all the symptoms can get worse, like double vision, droopy eyes, slurred speech, generalized muscle weakness. There can also be respiratory muscle weakness, but there is no respiratory failure. If this exacerbation is left untreated, then it can progress to become crisis. So in crisis, in addition to all the symptoms you have in exacerbation, it also has respiratory muscle weakness or bulbar, that is swallowing, facial muscle weakness, and this leads to respiratory failure, meaning the patient cannot breathe by themselves. They need mechanical, like ventilation, as in like intubate, and then they need the machine support to breathe. A lifetime prevalence of this crisis is about 20 to 30%. Now, there are certain differences between the two major types of MG. One is the acetylcholine receptor antibody MG, and then we have the MuSK MG. So there are certain muscles which are more affected in MuSK MG. That's bulbar, meaning the face, neck, speech swallowing muscles. And then the neck muscles are more affected, whereas in acetylcholine receptor antibody MG, it is the limb muscles, neck as well, but then it's more of a neck extensor. And then in MuSK MG, there is some muscle wasting, which is seen, like, or even muscle atrophy, which can be seen in facial muscles, more so in the facial muscles. And here it is more so in the proximal muscles of arms and thighs. So in thymus, there is no thymus involvement in MuSK MG, whereas there is thymic involvement in the acetylcholine receptor antibody MG. MuSK MG patients are more prone to develop crisis. That means, going into respiratory failure, speech, swallowing, getting involved, compared to acetylcholine receptor antibody mediated MG. Okay. Now, classification of MG, we can classify as early onset, late onset based on age, less than 40, more than 40. Again, less than 40, it's common in female. Ocular manifestation is first, but then they can present with generalized symptoms. There is thymic hyperplasia, and then acetylcholine receptor antibody is positive in these patients. Late onset is more than 40 years, mainly male. There is thymic atrophy or normal, or they can present with thymoma. So that's more so in late onset MG. We have MuSK MG. This is a younger age of onset, 20 to 30 years, more so in female. And like we mentioned, neck and muscle, respiratory muscle weakness and associated with crisis. We have the ocular MG and double seronegative. That means they don't have any antibodies, whether it's acetylcholine receptor or MuSK antibodies. There is another antibody called the LRP4, which we check in these double seronegative patients. Not everybody has that. About 10% in US population is what we see LRP4 antibody being positive. This is the MGFA classification. More so, we use this classification for clinical trials or research studies. We don't typically, give this classification on a day-to-day every clinic visit. As you can see, I know it's a very busy slide, but the key things are: class 1 is ocular, class 2 is mild weakness, 3 is moderate weakness, 4 is severe weakness, and 5 is respiratory failure and intubation. So what are the diagnostic tests we do to diagnose MG? So blood work, looking for antibody assays, acetylcholine receptor antibody, binding, blocking, modulating, MuSK, striational, and anti-LRP4. We also do CT chest or MRI to evaluate for thymic hyperplasia. This is a patient, one of my very first MG patients who presented with thymoma over here. This was when I was in med school. So that's one of the pictures I always carry with. So this is the electrodiagnostic studies like repetitive nerve stimulation, the torture test, where we see decrement as in like the fatigue in the muscle when we give repeated shocks or zaps. And there's also something called a single fiber EMG, which we do to look for electrically if we see the muscle fatiguing. And what are the different management options which are available? So I kind of differentiated or divided them into non-invasive and invasive. So non-invasive, the first one is acetylcholinesterase inhibitor like pyridostigmine or mestinone, which most of our patients are on it. So that's one. The second one is the immunomodulatory agent or oral pills or tablets, which include prednisone, azathioprine or Imuran, mycophenolate or Cellcept, cyclosporin, methotrexate, and tacrolimus in some refractory MG patients. Invasive ones are IVIG, it's an IV infusion, plasma exchange, thymectomy, and then we have newer therapies targeting the B cells like rituximab or ocrelizumab, targeting the complement like equitizumab, and then we have two new drugs. One is the rozanolixizumab or rozimab. It's still in clinical trial, but enrollment has been completed. Efgartigimod, which is also, the study is completed and it's pending FDA approval right now. So the first one, the pyridostigmine or mestinone, it's given through oral or IV, mainly metabolized in the liver. It's given about like more than 60 milligram 2 to 3 times a day. There are patients who take like 120 milligram 3 to 4 times a day. But typically we start with 60 milligram 3 times a day. This can be converted into IV, especially when patient has to be NPO or undergo any surgery, then it has to be converted into IV and can be used. I describe this medication as a Tylenol for MG. So it does not affect your immune system. As long as it is in your body, it helps to improve the symptoms. Once it wears off, your symptoms can come back, just like Tylenol for fever. Tylenol does not treat the underlying infection, it just reduces the fever. So that's kind of what pyridostigmine does to MG, but it's very effective in improvement of symptoms. Sometimes too much of pyridostigmine or mestinone can also cause some side effects or even weakness. So this is called as cholinergic crisis. So one can have nausea, vomiting, diarrhea, excessive saliva, or even bronchial secretions, runny nose, or teary eyes, abdominal cramps, muscle cramps, twitching, and even it can cause muscle weakness as well. Second is the immunomodulatory agent. Prednisone is most commonly used. It results in 70 to 80% remission in generalized and ocular MG. With the use of prednisone, sometimes we see initial worsening of MG symptoms after we start the treatment, probably in the first 2 weeks, 10 days to 2 weeks. But after that, the symptoms tend to increase. Symptoms tend to get better. We usually start 10 milligram per day and then increase by about 5 milligram every 3 weeks until we reach a maximum dose of 60 milligram. And some of the side effects is diabetes, weight gain, fluid retention, thinning of skin, easy bruising, anxiety, insomnia, increased appetite. So prednisone comes with its own package. Next we have Imuran or azathioprine, and all these three which are present below, they're called a steroid-sparing agent, meaning they have the similar effect on the immune system as prednisone, but much lesser side effects. For Imuran, we start 50 to 100 milligram twice a day. It requires about few months until it bears its effect or suppresses the immune system. And we usually monitor cell counts and liver enzymes on a monthly basis for the first 3 to 4 months. There is risk of skin cancer, lymphoma in less than 1%, and it suppresses both the T and the B cells. And next we have the mycophenolate mofetil, also called as Celsep. Again, 1,000 to 1,500 milligram twice a day. Even this medication requires few months until it can bear its immunosuppressive effect. And then we have to monitor the cell counts, liver enzymes as well. Cyclosporin, 25 to 50 milligram twice a day. It can cause renal toxicity, so we should closely monitor the renal function, and we have to increase the dose very slowly. Again, we have to monitor cell counts as well. So whenever we say immune suppression, doesn't mean that, it wipes out your immune system, especially in this day and age of pandemic. Everybody, is concerned about immunosuppressive drugs. So the way I would describe it as, it kind of tunes it down. So that's what it does. So next is IVIG. This is called intravenous immunoglobulin. And I know there's a lot of dosing information. We usually give 4 days of induction dose, back to back to back. After that, it's usually 1 to 2 days every 4 weeks. And this is, again, tailored according to the patient. Some patients might need every 2 weeks, some patients every 3 weeks, some do very well at 4 weeks. So again, it's not the same frequency or same duration for all MG patients. And it has numerous mechanism of action on how it does, how it affects the immune system. IVIG does not suppress the immune system. Some of the side effects are itching, rash, again, renal function monitoring, headache. It can cause something called as aseptic meningitis, irritation of the covering around the brain. In elderly patients who have had stroke or heart attack, it does increase their risk of that. And then thrombosis or blood clot in non-ambulatory, bed-bound or wheelchair-bound patients. Plasma exchange, again, this is through IV. So it's given as 5 sessions every other day, and then we do maintenance of 2 days every 3 weeks. Again, the 2 days every 3 weeks is not set in stone. It changes from patient to patient. It is a process where plasma is replaced. So basically, blood has 2 parts. We have the liquid part called the plasma, and then the solid part, which are the blood cells. So those 2 are separated, and then the liquid part, the plasma, is what is replaced, either with a similar protein to the human plasma or plasma donated by other humans. So, and then this is mixed with your cells and kind of returns back into your body. Some of the side effect is lightheadedness, drop in calcium levels, risk of infection. Here at Methodist, we do, our plasma exchange center, they do peripheral access plasma exchange, but not everywhere they do. Sometimes if the veins are not accessible, then it does require a central line to do the plasma exchange. Rituximab, it mainly targets the B cell. It does belong to a category of chemotherapy because it is used in a specific type of cancer called as B cell lymphoma. It's given through IV. Prior to giving rituximab, we have to get hepatitis panel, JC virus, PCR, and antibodies to JC virus. And the dosing is, there are 2 different dosings you can give. It's once a week for 4 weeks, and then we repeat it every 6 months. Or the maximum dose of rituximab one can get is 1,000 milligram. So you get 1,000 milligram IV, and then 2 weeks later, another 1,000 milligram IV, and then repeat after 6 months. Again, the patients can have infusion reaction. If one has had hepatitis in the past, it can cause reactivation of hepatitis. And then a small percentage of patients, they can develop PML if there is, if JC virus gets reactivated, which is a pretty serious disease. It's an infection of the brain. And then usually when one is on rituximab, we say to avoid live viral vaccination, not protein vaccine. You should not take live viral vaccination. Equitizumab, also known as Soliris, mainly acts on the complement system, and mainly it prevents the damage to the neuromuscular junction. Patients who have failed the typical or the classic treatment for MG, or who are pretty resistant or have a lot of fluctuations and exacerbations, then we tend to use equitizumab. It's given IV, again weekly for 4 weeks, and then a week later we get, and then the maintenance dose is once every 2 weeks. One of the side effects is there is a slight risk of meningitis. That's the infection of the brain by Neisseria, that's the bacteria species. So before start of this infusion, you have to have had vaccination against Neisseria or the meningitis vaccination, at least 2 weeks before the first dose. And then patients who are maintained on both equitizumab and plasma exchange, they do need a supplemental dose after the plasma exchange. So, like I mentioned, rozanolixizumab or rozimab and then efgartigimod are the two which are pending. One is still in the clinical trial phase. Efgartigimod is the one under FDA review. And these basically, the way they affect is basically the antibodies which are present in myasthenia patients, they all undergo recycling. And some of them, they escape those recycling. And these medication prevents that escape and make sure that antibodies are recycled and not going back into circulation. So that's their mechanism. And these are weekly infusions which are given, and then they're repeated weight-based again, and then they're repeated after about 8 weeks. And again here, we need to monitor IgG level. These are still not yet for prescription. They're yet to be, reviewed by FDA, and one is still in the clinical trial phase, so we cannot prescribe these medications yet, or these infusions. So perioperative management, here, before any surgery, we need to make sure that the patients with myasthenia are stable enough to undergo surgery. So with the plasma exchange, we typically say at least 24 to 48 hours before the surgery, just because your coagulation, as in like clotting factors and those proteins are regenerated back in your system. And if one is undergoing thymectomy, then we say to get IVIG at least within 10 days before the thymectomy procedure, just for it to be most effective, so that the patient doesn't go into an exacerbation or a crisis after thymectomy. So this was the article which was published in New England Journal of Medicine in 2016, which looked at thymectomy in patients with myasthenia gravis. So here they basically compared a group of myasthenic patients, 2 groups who were on prednisone alone, and then the other group was prednisone plus thymectomy. And then they enrolled patients between 18 to 65 years of age. And then as you can see on the graph here, and these are the MG scoring based on quantitative MG score, meaning it scores the weakness, the speech, the breathing symptoms, and all of those things. And then the patients who were on the prednisone alone, they had a higher score, whereas the one who got a prednisone and thymectomy, they had a lower score, meaning lesser symptoms, fewer symptoms. And the second one basically looked at prednisone dose. If one were able to taper them or lower the dose of prednisone after thymectomy, and yes, it was effective. They were able to lower the dose in the group who underwent thymectomy. There was also another thing they looked at is in patients, in elderly patients and younger patients. So the ones above 50 years of age did not notice a significant improvement after thymectomy, whether it is in the form of remission or in reduction in the dose of prednisone. There was not a lot of improvement after thymectomy versus the younger age group. So these are some of the drugs. There is a list in MGFA website as well. And we do give cards in our clinic to our patients, which has like a list of drugs, which are cautionary drugs, to carry it all the time in your wallet or purse. So some of these drugs I have highlighted just because, like certain of these are like antibiotics like Z-Pak, which, get commonly prescribed, or, like we have ciprofloxacin sometimes is also given frequently, and certain cardiac medications like beta blockers used for hypertension, calcium channel blockers, which are again used for hypertension. And then we have like, certain other medications. So here you can see there is prednisone as well. So we use prednisone to treat myasthenia, but at the same time, a very short and quick taper of prednisone, like it comes in a dose pack, can actually worsen or trigger MG exacerbation as well. So we have to be cautious when using those kind of a quick taper or a short course of prednisone. Statins, magnesium, iodine contrast, so these are all certain, other agents which one has to be cautious about. So magnesium, and I mention it here because one thing is when MG patients undergo colonoscopy, there are certain colon cleansing agents which have a lot of magnesium in it. And then some patients, do notice worsening of MG after colonoscopy, not because of the procedure, but because of the cleansing agent which they used. So that's something, like to look for, especially, if one is undergoing colonoscopy. And these are special consideration during especially pregnancy and MG. So new onset MG can occur during pregnancy, during first trimester, or in the immediate postpartum period. 66% of women might notice worsening of symptoms in first trimester, but about 20 to 30% notice improvement in second and third trimester, mainly because pregnancy in itself causes some level of immune suppression, and that kind of helps with MG. Severe exacerbations can be seen after delivery, like 3 weeks postpartum. And also treatment during pregnancy for MG is individualized. One can take mestinone, prednisone, plasma exchange, IVIG, but again, this has to be done in close monitoring, and after the obstetrician gives the okay, only then these treatments can be initiated. So we have come a long way from 1600s to 2021, and as you can see, these green arrows are all like discoveries made, like how MG is caused and what causes MG, and these orange triangles are all the surgical procedures like thymectomy, and then the blue triangles are all the drugs which are available, oral or IV, and the red one is mainly IV infusions, or like plasma exchange or IVIG, like blood-derived products. So that kind of, as you can see here, almost till like 1967, there was nothing other than just like different forms of like physostigmine, neostigmine, pyrostigmine, all different forms of that. That was the only treatment, and it was only 1967. You can see, like, azathioprine was used, and really it is more after 2000s is when like all mycophenolate, rituximab, tacrolimus, cyclosporin, and then the newer drugs here came into existence. So I know we have come a long way, and it's exciting time that we have a lot more options to offer our patients. With that, I'm gonna conclude my talk. Thank you.
Thank you, Dr. Shroff. So we're opening it up for questions. Please post your questions on Poll Everywhere. I have a question that I'm often asked by patients is how to know which treatment is best for them. They hear about other patients who may be on another medicine, and they're wondering if that medicine is best for them. What do you tell a patient?
So typically, we start with like the standard or like the first line treatment option. And again, like not all treatment doesn't work the same for all the patients. Even though MG is one diagnosis, each patient with MG is different from one another. So say even like plasma exchange and IVIG both are first line, some patients respond to plasma exchange better and some patients respond to IVIG better. And there is no one test to kind of find out who responds to which treatment better. And it's only like, we have to initiate the treatment and see how they respond, and if they're not responding, then we have to change them over or switch them over to the next treatment option. And the same way, even with oral medication, azathioprine or mycophenolate, like both are first line drugs. So there is no, it's just, more like a flip a coin, and you choose the drug and then see if that works. And of course we have to take a look at like, okay, liver function is okay, is it okay for that patient to take azathioprine or mycophenolate, or is renal function okay, can we start cyclosporin? So those are some things, yes, we do look in the blood work. But overall, there is no way to say this one treatment is gonna work 100% unless we start it and try it out.
Thank you.
Yeah.
All right. For the sake of time, we're going to go on to the next discussion. I believe that's me. Wonderful. Okay, if we can have the slides up. So I'm going to talk about the current and advancing therapy in myasthenia gravis. There we are. And we need the presentation slides, please. Thank you. While we're waiting, I'm sorry, forgive me, it's not my turn, it's Dr. Cowell. Okay, I'm actually so excited to give my talk. I was going to circumvent Dr. Cowell, how dare I. Welcome, Dr. Cowell. Dr. Cowell is an associate professor of...
I can't hear Dr. Green.
Yes, I'm going to introduce you if that's okay. Can you hear? Dr. Cow, I'm going to...
Oh, okay, now I can hear you. Good.
Wonderful. Technology has afforded us so much in the way of access, but we're still trying to navigate. So Dr. Cow is a professional colleague. She is an associate professor of pulmonology and critical care medicine at Stanford University. She's actually been involved and has special expertise in the management of respiratory issues and ventilation in patients with nerve muscle disorders like myasthenia gravis. She's going to give a talk on the respiratory issues in myasthenia gravis and its management. Doctor?
All right. So the agenda for this 30 minutes is number one, to discuss the signs and symptoms of respiratory weakness in sleep and daytime, discuss testing for respiratory weakness and the treatment with non-invasive ventilation, and discuss myasthenia exacerbation or crisis in the care of the hospital setting. And we will end with a review on COVID-19 and pneumonia vaccination recommendations. So this is a sort of a summary slide to put together what happens with patients when it comes to breathing who have myasthenia gravis. So you can see here that there are multiple areas of involvement. There is involvement of respiratory during sleep, also during the daytime, and then there is swallowing impairment, as well as the inability to clear airway, respiratory airway secretions. All this can lead to respiratory failure, which can be acute or progressive and chronic. So I put together three categories of how respiration or ventilation can affect myasthenia gravis. So which can lead to elevated carbon dioxide and low oxygen levels in the blood. This can happen during sleep as well as daytime. There's also involvement of the bulbar muscles. These are the muscles of the neck and the face. This can lead to obstructive sleep apnea, which is a breathing problem during sleep. And then also there is impaired, you can have cough impairment and the inability to expectorate or clear secretions from your airway. This can lead to aspiration, pneumonia, and so forth. This is sort of a nice diagram of what happens with patients who have diaphragmatic weakness and or bulbar muscle weakness. So starting from the top, you can see that what happens during sleep is that there is reduction in oxygen levels, and there is a corresponding increase in carbon dioxide in REM sleep, which is deep sleep. This can lead to arousals, repetitive arousals from sleep, which is sleep fragmentation. That leads to a reduction in total sleep time and sleep efficiency. So these patients will have excessive daytime sleepiness and neurocognitive impairment. And if this cycle is unchecked, eventually patients can develop respiratory impairment during the day. So the cycle repeats itself unless we can correct it. So this nice diagram sort of puts everything together in terms of how respiratory weakness can affect patients. So there's the inspiratory muscle weakness, right? When these are muscles that help with inhalation. The weakness in inability to inhale and take deep breaths can lead to ventilatory dysfunction. This is basically, again, the elevated carbon dioxide and low oxygen levels, and if left unchecked, can lead to daytime respiratory problems. The expiratory muscle weakness are muscles that help with expiration, so muscles that help also with cough. When you cough, you use these muscles. So if these muscles are weak, there is a weak cough, which can lead to pneumonia, aspiration, and so forth. And then the bulbar muscle weakness, as I mentioned before, this can lead to upper airway dysfunction, which is upper airway closure during sleep, which is sleep apnea. And you can see, though, that these are all intertwined and they all correlate in terms of how they interact, all these three muscle groups. So it isn't just one area that's affected by all three areas. So in terms of symptoms to watch out for, so I broke it down to night symptoms and daytime symptoms. So nighttime symptoms can be something as frequent arousal. So these patients can complain of insomnia because they feel like they just can't fall asleep or stay asleep, but that's because of the breathing issue that's triggering the arousals. Patients can complain of unrefreshed sleep upon awakening. Patients may be actually sleeping longer to compensate for that frequent arousals and lack of quantity and quality sleep. And then also symptoms of sleep apnea include snoring, breathing pauses, or gasping and choking from sleep. Corresponding to the daytime, I think many patients complain of daytime fatigue. That's pretty common, and also excessive daytime sleepiness. Patients may have morning headaches, especially if the carbon dioxide levels are elevated. Patients may increase nap duration or frequency, or just have new naps when they were napping before. All of this can have mood changes, and in the severe stage, there's frank shortness of breath. So let's move on to the evaluation and testing for respiratory involvement. So there are two main categories of testing. There's the pulmonary function testing, which is a test for daytime breathing problems, the measurement of lung capacity and how the strength of the respiratory muscles. And then there's a sleep study, which tests for nighttime breathing problems and also can test for conditions that are unrelated to breathing. So the pulmonary function testing, for the purposes of myasthenia gravis, we look at these four measurements. So the SVC is the forced vital capacity. This is a global measure of respiratory muscle strength. So we're measuring all the three muscle groups, right? The inspiratory muscles, expiratory muscles, bulbar muscles. And then the MIP is maximal inspiratory pressure. So this is the strength of more of the inspiratory muscles and also the diaphragm. The MEP is the maximal expiratory pressure. These are measurements of muscles that help with cough and expectoration. And then we also measure the peak cough strength, which is PCF. And I'll give you values of normal and what to expect when it's abnormal. But to stress that, the pulmonary function testing really should be the first step in assessing for breathing weakness in myasthenia patients. So these are sort of normal values, approximate values of what's normal. Obviously, it depends on your height and your size and your age, but in general, these are some numbers to look for or to remember. So the FVC, if it's greater than 80% predicted, is considered normal. So this is based off normal values in a large population of normal individuals. And so if, we also measure in liters, and so approximately 3 to 5 liters is normal, depending on, again, you're a woman or a man and your size and your age. The MIP, relatively speaking, these are normal values, greater than 100 in male and greater than 80 in female. The MEP, greater than 120 in male and greater than 100 in female. The peak cough flow is a measure of cough strength. So if you can score about 500 liters per minute, then it's considered normal. And then if you're doing an arterial blood gas looking for carbon dioxide, normal range is around 35 to 45. Obviously, 45 is approaching the high normal range. And so in terms of getting approval for treatment with non-invasive ventilation or BiPAP, so to speak, these are the criteria to get approval. So these numbers are something to know. So if you're getting an evaluation, you can also ask your providers, what your numbers are. But you have to have the first 4 items. You have to meet one of these 4. You don't need to meet all 4, but one of the 4. And so the first 2 are going to be the easiest to obtain in terms of getting that pulmonary function testing. So your FVC, they're looking for less than 50% predicted. And then the MIP is less than -60. So for example, -50, -40, and so forth. It is a little harder to get the arterial blood gas because you have to go to a pulmonary function lab and you have to schedule for it. But if you do get that, then it's the abnormal value is greater than 45. Keep in mind that if this is actually if this is the result, that means that there's already evidence of daytime respiratory weakness. And then also, providers can order an oximetry testing with at least a minimum of 2-hour recording to be valid. And they're looking for an oxygen saturation of less than 88% for 5 consecutive minutes. And then lastly, when the provider qualifies you for treatment, there's also has to be an attestation in the clinical note saying that the patient doesn't have obstructive lung disease such as COPD or sleep apnea. What about a sleep study? So a sleep study is a great tool because it can identify obstructive sleep apnea or CO2 retention during sleep. And it helps when the patient's pulmonary function testing is relatively normal, but maybe there is suspicion that there's something going on during sleep. And also it helps when the patient is on PAP therapy, like BiPAP, but the settings seem to be inadequate and inappropriate, and we can't seem to get it right. So we can actually do a sleep study with BiPAP to test out the settings. So just keep in mind that, like as I mentioned before, that a sleep study is not necessary because the patient can be qualified for BiPAP therapy based on the pulmonary function testing results. But if isolated sleep apnea is suspected, then a sleep study is necessary in order to get CPAP approval. So let's move on to treatment. So I recommend that you should get the pulmonary function testing periodically, and it really depends on your disease severity. How often are you fluctuating? So it can be anywhere between 3 to 6 months up to once a year if someone is quite stable. So advanced positive airway pressure, these are PAP devices, right? Positive airway pressure are otherwise commonly known as non-invasive ventilation. So a lot of providers will say NIV, and that's what we mean. Using a mask interface, this is the prime recommendation to support breathing during sleep and during the daytime if needed. CPAP therapy, continuous positive airway pressure with a mask interface, is recommended for isolated obstructive sleep apnea alone without respiratory muscle weakness involvement. So these are the categories of different devices, and I listed different. So for example, the auto PAP devices. So these are the CPAPs and the bi-level PAPs, and this is for obstructive sleep apnea patients. The respiratory assist devices are the more advanced devices, and this is for isolated breathing weakness during sleep. And These are more advanced devices with a backup respiratory rate, and it's non-invasive use. It is not portable for those of you who use it. It does require electricity. And then the home ventilators are really meant for patients with very severe weakness, usually progressing to the daytime. And these are with the ability to offer non-invasive and invasive, which is used for the tracheostomy. And these are just the available ventilators in the market as of today for the United States. So just a quick slide on what is the difference between CPAP and BiPAP, and I get this a lot, right? So CPAP stands for continuous positive airway pressure. So it doesn't matter if you're breathing in or breathing out, you're getting a constant pressure. So for example, if I set the CPAP at 10 centimeters of water pressure, it's just going to get that continuously. The EPR is just a nice comfort measure where during exhalation, the pressure can just dip momentarily just to improve, for comfort when you're breathing out against that pressure. BiPAP is completely opposite, right? So look at the continuous positive airway pressure. For BiPAP, when you inhale, there's a higher pressure. When you exhale, there's a lower pressure. So actually, the IPAP is inspiratory positive airway pressure. The EPAP is expiratory, and it will switch during inhalation, exhalation. And you can see here the corresponding breath, right? Inhalation, exhalation. So BiPAP is more advanced, and obviously it has to correlate or synchronize with your breathing. So if it doesn't synchronize well, then it can be a little bit uncomfortable. So patients always ask me, which device is best for me? So my answer is it really depends on the severity of your disease. So in early stage, when your pulmonary function testing is relatively good or normal, and you have isolated sleep, breathing weakness in sleep, then I recommend using a BiPAP device. And this is obviously, beyond sleep apnea. And I recommend starting with low pressures to allow time for adjustment before increasing the pressure. For patients with difficulty breathing during the day who have more severe disease, then I try to go straight for the ventilator. And so that's how I decide which patients should get what. Just a quick slide on insurance requirement. So this is a point of contention for many providers and patients because you really have to know this well. Otherwise, patients don't get to continue their treatment. For the CPAP and bilevel devices, there's this 90-day compliance requirement, which means that you have to demonstrate 4 hours of use per night, and it's a 70% of use in a 90-day period. So basically, approximately about out of the 90 days or 3 months, 30 nights or 1 month, there has to be 4 hours of use per night consecutively. So you can't use for 1 week and then skip for 2 weeks and then use it again for another week. It doesn't work that way. So this is that compliance requirement. And the second one is that there has to be a face-to-face follow-up with the prescribing physician to document that you are using it and it's effective. But the compliance is actually an objective report that is downloaded by the device itself. So the DME companies will do that and submit it to insurance. If this is not met, the treatment is stopped, meaning you can still use the device, but you can't ask for a supply refill, and the company will want to get their machine back because they're not getting reimbursement from insurance companies, and they will bill you if you don't return the machine. So this is that point of contention that I think a lot of providers may not realize and patients may not realize. For the ventilators, it is less strict, but I will say that some insurance policies will still require 90-day compliance criteria, but for the most part, it is not as strict as the CPAP and bilevel PAP devices. So what about CPAP? So in general, I like to say that CPAP is contraindicated for patients who suffer from respiratory weakness because, as you can imagine, when you breathe in, you get that high pressure. But when you breathe out, you're breathing against that high pressure because it doesn't drop, right? So it can increase work of breathing. It can cause diaphragm fatigue because the diaphragm is working harder during exhalation. That being said, if you just have sleep apnea, then CPAP is the recommendation for that. I also want to talk about mask fitting. So a good mask fit is so important for effective use, whether it's with CPAP or BiPAP or the ventilator. And there are 4 options here. So there's the pillows, the nasal type, the oral nasal, which is the full face mask, and this is total face mask that most people don't really use. These are the common causes of mouth leak. Mouth leak is very common. I actually think mouth leak is It's something that everyone deals with when they use PAP therapy. But look at this here. So the advantages of a nasal mask are numerous. It is more comfortable. You need less pressure requirement. The overall leak is lower. There's less risk of aspiration, less risk of air going to the stomach, which is aerophagia. There's that risk of mouth leak, of course, but that doesn't mean that it needs to be treated. And the full face mask, there's many more disadvantages and very little advantages. So what I mean is that we always start with a nasal or a pillows type mask, even if the patient has mouth leak, and only if we need to, we'll go to the oral nasal mask. These are some of the options, just prototypes of different mask interfaces. The goal here is really to choose the best fitting and the most comfortable mask that you think is best for you. And that's the most important aspect because you have to be able to wear the device. What about oxygen? So oxygen is a problem when it comes to neuromuscular disease in general. And because what happens is that if you use, the issue here is that there's muscle weakness. The lung tissue is not a problem. So if you add oxygen, it actually sort of falsely tells the brain that you don't have to breathe so much, and then your carbon dioxide gets elevated. So it's falsely reassuring because the SpO2 monitor will have a high level of oxygen saturation, but it doesn't measure carbon dioxide, and that can also rise as well. So oxygen is not indicated for myasthenia in general. However, that being said, oxygen can be used if the patient has something else going on besides myasthenia. So, for example, you can have other conditions such as COPD, heart failure. Those conditions may require oxygen. So it doesn't mean that oxygen can never be used, but we have to understand what is it being used for. So in terms of getting hospital care for myasthenia gravis, so I think in general for patients with myasthenia who comes in with respiratory symptoms, most of these patients should be monitored in a intensive care unit level or at least a step-down unit with close monitoring. And the recommendation also is to start non-invasive ventilation right away, immediately, along with mechanical airway clearance so that we can reverse that cycle of shortness of breath and work of breathing and so forth, so that patients don't end up getting intubated. That being said, acute myasthenia crisis is commonly also associated with severe bulbar weakness, right? So the bulbar muscles, again, are the neck muscles, and this can lead to a high aspiration risk. And if the patient aspirates, then that's very problematic. So even though we recognize NIV early, we still try to promote early intubation if this is what's happening to the patient. And unlike other neuromuscular disease such as ALS, we do our best to not intubate the patient by any means. In this particular case, we can intubate because there is effective options for therapy, right? So there is plasma exchange, and there's also IVIG. So getting the treatment means that your respiratory function is going to improve. So we can wean you off and get you extubated and off the ventilator. Something to think about when you're in the hospital is that how often do we measure the respiratory muscle strength, right? So we measure the FVC. A lot of people will measure this, very commonly every 2 to 4 hours, 24 hours a day. And I think that's not necessary. I think it's important to measure maybe 2-3 times daily. But I think most importantly, we want to avoid doing this at night so patients can sleep and rest. There's no reason to do this at 3 in the morning. These are some numbers to go by. If the FVC, the vital capacity, is less than 15 to 20 mLs per kilogram, this is very, very low. Means that the patient is getting very low volume of air with each breath. And this is a high risk for a patient who's going to crash and get intubated. And also, these are other measurements as well. And if the patient is not intubated yet, we want to, again, I can't stress enough, we want to monitor closely for bulbar muscle weakness, right? So that these patients may develop dysarthria, dysphagia, or worsening of these symptoms. Impaired gag reflex, the facial weakness may get worse, and inability to cough at all. Okay, so I have a few slides left on vaccination in general, and let's start with the COVID-19. So a lot of people will ask me about, vaccination, and because I have myasthenia, should I get vaccinated? Is it going to put me at risk? And it's really the opposite. I think that all patients, including myasthenia patients, should get vaccination based on the CDC guidelines. And this also goes for the booster. Okay, so the booster guidelines just came out, and it is for anyone who's 65 or older, those with immunocompromised status, healthcare workers, and medical conditions that can put the patient at high risk of severe COVID-19 pneumonia, meaning that whatever medical conditions you have, you might be at risk for. If you get COVID-19, you can have severe pneumonia and hospitalization and death. So these are the patients with compromised respiratory strength, right? So not all myasthenia patients are going to be in this category, but some of you will be. And especially if you're dependent on non-invasive ventilation, especially full-time or during the day or nocturnal. So I think that there is a category of patients who are at high risk for severe COVID infection who should get the vaccination and the booster. What happens if you're exposed to COVID or you have a known infection? So there's a REGEN-COV is a monoclonal antibody that was just approved by the FDA in August. And it's not being highly prioritized because it is hard to get, and it does require an infectious disease specialist to authorize this, but it is recommended in non-hospitalized, mostly unvaccinated patients, because if you're vaccinated, chances are you're not going to get severe infection. But these are patients who, again, have a high risk of getting severe COVID, pneumonia, and hospitalization and death. So it is recommended for post-exposure prophylaxis. So if you know that you were just next to or exposed to someone with COVID-19, or if you have a confirmed infection that's mild to moderate, meaning you're still at home and you're not hospitalized. And also, if you have an exposure, or especially if you're infected and you're at home, please continue to use the PAP therapy. And you might need oxygen, and oxygen can be added to the device. It is important to clean that PAP equipment, the mask, the tubing, the gear, daily, and practice CDC isolation guidelines based on just the general guidelines. Let's move on to vaccination recommendations for pneumonia in general, right? Because we're approaching the winter, and this is the season where pneumonia is most prevalent. So pneumococcal pneumonia, the reason why we focus on this is because the pneumococcus bacteria is so virulent, and it is highly contagious, and it is very lethal. Patients can die from this pneumococcal pneumonia, unlike other types of bacteria and viruses. And there are two vaccines available. There is the pneumococcal conjugate vaccine, we know it as the Prevnar 13, and then the other one is that Pneumovax 23, and you probably hear about this all the time with your PCPs. The other one is the influenza pneumonia, right, which is also can be very severe if you get hospitalized. Most patients get intubated, get on the ventilator for weeks, and many do not make it. So that's a flu vaccine. So this is just a table for you to have, and you can look at this at your own view, but I wanted to just quickly go over the recommendations. So the 23 valent, okay, this is actually mainly for young patients younger than 64, so adults 19 to 64, with the following conditions: smoking, chronic heart disease, chronic lung disease, chronic liver disease, diabetes. You might say, well, how does that apply to me? Well, if you have myasthenia gravis and you have impaired respiratory weakness and you are on a non-invasive ventilation device, you have chronic lung disease. So you are at risk for severe pneumococcus pneumonia. It's also recommended for those greater than 65 years old. But younger than 65, unless you have these conditions, you don't have to, it is not recommended. The 13 is generally recommended for 65 years and older, and also those at increased risk of infection. So this is really for the patients who are greater than 65. And so anyone can get it if you're greater than 65. But if you are in this category, then it is highly recommended, right? So those who are living in areas with low vaccination for kids. So the pneumococcus is, as you know, it's recommended for all children get this vaccine because children can pass it on to adults very easily. Also, again, here it is, the chronic heart and lung and liver disease, smoking, alcoholism, diabetes. So myasthenia gravis, many patients have other conditions, including diabetes and heart disease. those who live in nursing homes or long-term care facilities, and immunosuppression. It is really not recommended for those less than 65 unless there are very specific criteria for this. So I won't go into that. And then the influenza vaccine, as you know, is recommended for all ages. However, if you're less than 65 years old, specifically, these are the conditions where you can have severe influenza and pneumonia, putting you in the ICU with intubation. Again, chronic heart, lung, and disease, and diabetes. So these are some very common medical conditions that you can have in addition to myasthenia gravis, right? But the chronic lung, as you can see here, is in all three categories. And this is why I think that it is important for myasthenia gravis to really consider these vaccines. So in summary, look for nighttime and daytime symptoms that may suggest the presence of obstructive sleep apnea, as well as breathing weakness in sleep and daytime. Monitor lung function testing regularly, depending on your disease severity. A sleep study is helpful if obstructive sleep apnea is suspected. CPAP is effective for sleep apnea. BiPAP, or non-invasive ventilation, the more advanced modes of BiPAP therapy, is effective for breathing weakness in sleep or daytime. And remember that BiPAP and NIV devices will also treat sleep apnea. If cough strength is impaired, assisted airway clearance is recommended to prevent aspiration and pneumonia. And then if hospitalized, advocate for early use of non-invasive ventilation and mechanical airway clearance. And lastly, SARS-CoV-2, which is the COVID-19, influenza and pneumococcal vaccines do help to prevent severe pneumonia, hospitalization, and death for patients with respiratory muscle weakness. And that's all I have. So thank you.
Thank you so much, Dr. Cow. That was excellent, very thorough. We have a number of questions, some of which are delayed from Dr. Schroff's talk, but we have a question for you, which I'll show. Okay. It should be coming up, but I will read it. Does the oximeter work for the MG patients? If it doesn't, how can we tell the ER staff that it doesn't work? And what will work that we can recommend they use? That is, if we can and are able to communicate these concerns. Very good question.
Okay. I'm assuming this is pertaining to patients in the ER?
Right. So I think the question is how do we, especially when in the ER, they don't know these tests to do, which can happen, and how does a patient advocate for themselves?
Yeah, so the oximeter does work in the ER, but remember that it only measures oxygen level, which is really the last thing to drop in patients with myasthenia gravis and who's having exacerbation with respiratory compromise. So what they should really do is do the arterial blood gas analysis, and also, of course, measure the FVC and the maximal inspiratory pressure. So you can, your caregiver or you as a patient can tell the ER physician, the providers, to do additional testing, including arterial blood gas and the pulmonary function testing. And hopefully they would also try to consult a neurologist if you are admitted.
Yeah, I can't agree more. I think that if you find yourself going to the emergency room, notify your neurologist, make sure that you advocate for yourselves. This is why we give you the information. And at the very least, maybe ask a pulmonologist to be called to the case as well. But having the knowledge, I think, is your best defense versus just not knowing.
Yeah, I think the oximeter, like I said, it's falsely reassuring because it's gonna, they're gonna put you on oxygen and it's gonna be 98%, and it looks great and everyone is happy. But that is not, that is falsely reassuring. So you want to tell them that my oxygen is fine, but I'm worried about my CO2 level. And if you have a BiPAP at home, if you want to bring it and you show them that, hey, listen, I'm on a BiPAP at home. And they would probably know that you have something beyond just an oxygen issue.
Thank you, Dr. Kawa. We have some delay in some of the questions. I know that you have other things scheduled today, but if
I'm okay. I'm okay staying for now if you have time.
Yes, I think some more questions will be coming through, so I thank you. We're going to bring Dr. Schroff back up. She has been answering many of the questions on the live chat. I just will say that this program and all of its presentations will be available after the conference for all of our registered attendees, so that you can go back through the information at your leisure. So, Dr. Schroff, I will also say we've had a number of questions about COVID, vaccinations, and infections. We're going to try to save those to the end so that we can cover all the bases at one time, if that's okay. So I'll let you choose. Which one do you want? It's just
Not that. Yeah, this one. I just have to tap on this, right?
and it'll be visible.
Yeah.
Just wait, it'll take a little time.
So the management details about MG exacerbation and crisis will be covered by Dr. Anderson later today. So I think, like you'll get all the details about that later. Yeah, our cytostatics can be, so cytostatic means, these are the drugs which kind of stop or reduce the cell proliferation. So some of the drugs which we use, like azathioprine, mycophenolate, so all of these, they do have cytostatic property, as in like it does reduce the proliferation of these T and B cells. So I hope that answers your question. Yeah, so MuSK-MG is diagnosed, there's an antibody called MuSK antibody, so it's a blood test which we do. Acetylcholine receptor antibodies are one type of blood work, and then MuSK antibodies another blood work. So if those antibodies come back elevated, then with the clinical features of MuSK-MG, then that's when we diagnose with MuSK-MG. I think Dr. Green answered this question. There will be yeah. So can you stay on CellCept while on Rituxan? So depending on how bad your MG is, you might have to be on 2 immunosuppressants, or if Rituxan is more effective and it can be and it's well controlled, then you might not need 2 immunosuppressants. So it's just a matter of like how severe your MG is and how well you're responding to rituximab. So that's kind of how one might have to decide whether you need to be on both or not. Yeah.
Thank you. We really appreciate your questions today. We see that there are a number of them. So if we haven't answered them live during the discussion, we are answering them within the chat. There have also been some questions that are more of a personal patient-specific basis from an attending who is from out of the country, and we will reach out to you offline if that's okay. We have another question for Dr. Kao. It's the top question, Doctor.
Sure. Can you explain the role of CO2 monitoring for ventilator users? Yeah, so it is possible to monitor CO2 with the ventilator use at home. However, you would have to work with probably your pulmonologist or your neurologist and the durable medical equipment company, because it is a transcutaneous system and it is a continuous monitoring that's connected to the device and on your skin. So the DME company would have to have this device and capability to do it. I would say it's not commonly available across the country. There are a few institutions who have this, but that's how we would do it. Otherwise, the only other way to monitor CO2 with a ventilator is in a sleep lab.
Okay. Here's another question. The top question.
Oh. That's a question for Dr. Green. Just joking. How to find a pulmonologist with experience in MG. I think in general, there is a lack of pulmonologists with experience in neuromuscular disease in general, as well as MG. It's probably best to ask your neurologist, because usually your neurologist will probably know the community and know who they work with, and that would be the best resource, in my opinion.
I agree with you. Ask the neurologist, because not all pulmonologists feel comfortable or have that much experience. Unfortunately, it's a minority, but we are spreading the word. We are training. And many neurologists have had to function as a pulmonologist in terms of advocating for their patients and in the ICU. So I agree 100%.
I do think that many neurologists who practice neuromuscular disease are much more experienced with managing respiratory compromise than pulmonologists.
All right. Well, we really are excited about your questions. Keep them coming. It is time for our break. And so we will break now. We're right on schedule. And this will be a lunch break. So it is a 30-minute break. We will return for Dr. Anderson's lecture on the management of exacerbations in crisis. She'll go into more detail about how to recognize the signs, what's the difference, and how it's treated and what you need to know and do. And that will be at 11:55. During the break, I welcome you to go to the sponsor hall and talk to our industry sponsors, as well as we have videos of patients who've given their testimony, sort of talked about their journey with MG, as well as Dr. Anderson has a podcast about navigating the ER. At this point, we'll break, and we'll see you back in 30 minutes.
My name is Dr. Ashley Anderson, and I am one of the General Neurology and Neuromuscular Medicine faculty at Houston Methodist. Today, I will take a few moments to speak with you about how to navigate the emergency room should you ever need immediate care for a worsening of myasthenia gravis symptoms. This worsening is often termed a myasthenia gravis exacerbation. You will learn more specifics about a myasthenia gravis exacerbation and details on treatment options during this conference. We sincerely hope you or a loved one are never in a situation where you must use emergency services for any reason, including a worsening of myasthenia gravis symptoms. However, should the unfortunate situation arise where you need to go to the emergency room, we want to help you be as prepared as possible. An important step in being prepared for an unexpected situation is doing exactly what you are doing now, which is taking time to educate yourself and your family on myasthenia gravis. This knowledge will allow you to better identify and explain your symptoms to the healthcare team and be an active participant in your treatment plan. Also, you should have an updated list of all of your medications, including those you take for myasthenia gravis. This includes any oral medications or other treatments, including infusion therapies or plasma exchange. We recommend you keep this list readily available so you can provide this to the emergency healthcare team. You will also want to keep a list of medications that should be used with caution or avoided in patients with myasthenia gravis. This includes certain anesthetics, antibiotics, and antivirals. A list of these medications will be made available to you. So you may wonder when to go to the emergency room. You should go to the emergency room if you're having the following symptoms. 1, increased difficulty breathing. 2, increased difficulty swallowing. Or 3, progressive weakness, including weakness in your neck, which prevents you from holding your head up, or weakness in the arms or legs, which may prevent you from performing your typical daily tasks. If you are not sure what decision to make, you should always err on the side of caution and go to the emergency room. While you may want to contact your neurologist's office, do not wait on a response as to whether you should go to the emergency room. The response from your doctor's office may not be immediate, and time is of the essence. Furthermore, I can understand you may be concerned about going to the emergency room during the pandemic. However, wearing a mask, social distancing, using hand sanitizer, and limiting touching your face or other objects allows for the emergency room evaluation to be performed safely. Once at the emergency room, you will likely be seen by a triage nurse or other staff member. You will need to be specific about your symptoms and inform him or her about your diagnosis of myasthenia gravis. This will allow the team to better prioritize the care you need for your specific condition. Please make sure to also provide your home medication list. As part of your evaluation, the emergency room physician will perform an investigation to try to find a reason for your exacerbation. This will include looking for possible infection, such as respiratory infections, including COVID-19, physical stresses, such as a recent surgery or accident, or a new medication or exposure. Please be prepared to share any thoughts with the emergency room team about any recent changes or symptoms which may provide pertinent information about your situation. It is crucial that one of the first evaluations to have in the emergency room is bedside pulmonary function testing. Pulse oximetry or respiratory rate are not sufficient to evaluate your respiratory status. The 2 pulmonary function tests we focus on are 1, the negative inspiratory force, or NIF, or maximum inspiratory pressure, MIP, and 2, the functional vital capacity, or FVC. The NIF, which is also called the MIP, is a measure of diaphragm and accessory breathing muscle function. The normal value typically ranges between 70 to 100. We become concerned when this value ranges from -20 to -30. It is at this point we believe the diaphragm is too weak to effectively help with ventilation. The NIF should be measured both sitting up and laying down, as there may be a more significant reduction in this number when laying down. The FVC is a measure of your breathing status, looking at how much you can breathe out after breathing in. This is normally between 3 to 5 liters. When this number declines to about 2 liters or less, there is decreased ability to clear secretions and a weakened cough. If your respiratory function is a concern, we first want to try non-invasive ventilation, such as BiPAP, or bi-level positive air pressure. This is a machine which uses air supplied by a mask over the face to offer respiratory support. We want to prevent intubation, but elective intubation may be considered if there's a trend of a decline in your pulmonary function testing, or if you are having more difficulty breathing. Your pulmonary function should be monitored regularly. In addition, your swallowing function needs to be evaluated to prevent aspiration, so food or liquid does not go into the airway or lungs. After these evaluations in the emergency room, you are likely to be admitted to the hospital for ongoing care, which will include management of any infections, any electrolyte disturbances, or the removal of any exacerbating medications or supplements. Medications should be chosen carefully and, if possible, all safe alternatives should be considered. In addition, you may be treated with intravenous immunoglobulin or IVIG or plasma exchange. Once you are stable, it is at this point you or a family member should inform your primary neurologist about what has occurred. Near or at the time of hospital discharge, we recommend trying to make a follow-up appointment with your neurologist within 1 or 2 weeks. If an in-person appointment cannot be scheduled, please reach out to your neurologist to discuss your current health status and any potential next steps. This may be a lot of information to retain. So an emergency checklist for myasthenia gravis emergencies has been provided with an outline of the points of this talk. I want to stress the importance of this information, not to scare you, but to empower you. You are your best health advocate, and being informed is a crucial part of improving your quality of life. Our speakers today are experts in their field and are ready to provide you with valuable information. I want to thank you for your attention and being an active participant in this conference. Hello, everyone. My name is Dr. Ashley Anderson, and I am one of the general neurology and neuromuscular medicine faculty at Houston Methodist. Today, I will take a few moments to speak with you.
I've had MG for 11 years, since I was 19 years old. When I was first diagnosed, I was in my undergrad, so it was my first time living by myself, and it was a little scary. And when I went home to get diagnosed, shortly after I had a thymectomy. After my thymectomy, after a few years, I started IVIG treatment, which I would get once every 4 weeks for about 5 to 6 years. And when I was 26, we decided to start a different treatment because IVIG was just not as effective as we'd hope. And I started Imuran, and I couldn't tell right away, but I was able to tell later on that it was working. And I'm able to do more now than I was in the past. Some of my first symptoms were my facial features. I couldn't really talk or eat or close my eyes all the way. I still have some weakness around my mouth at times, but not to the extent that I can't talk or eat, which is really good. A few years after, I started experiencing general myasthenia gravis, which was throughout my entire body, which was weakness in my legs and my arms. I couldn't dress myself. I couldn't do my makeup. I couldn't do my hair. So it was very frustrating because I was in school. But the treatments have definitely helped, and I guess the years of knowing what does affect my myasthenia gravis and what doesn't helps. Like if I knew back then that the weather and stress affected me as much as they do, I would have probably done things a little differently so that I wouldn't go into crisis modes. And also my support groups, being able to speak to someone that has MG has definitely helped, to be able to speak to someone that understands exactly or close to exactly how you feel with the symptoms and the medications and side effects of everything has definitely helped.
Some of my experiences since developing myasthenia gravis. About 12 years ago, I started feeling tired and not having a lot of energy. And so I went to my family doctors, and they all said, well, you're a single woman, you're depressed, you're overweight. Well, I felt that there was something more than that. So I came to Methodist and found Dr. Erica Simpson, and my world has changed. Dr. Simpson had listened to what all I had to say, and then she had me walk down the hall, and I believe at that point she knew what I had. and then followed up with a test to prove it. After that, she started prescribing medicines for me, and I have to say, I was upset about how many pills I had to take because I thought only old people took that many pills. But the pills began to help. I also started with plasmapheresis. And between my pills and plasmapheresis, that has been my treatment for the last 12 years. At that time, I was not able to move my neck very much. I wasn't able to do the things that I'd always done. They tried to tell me I was a type A personality, and I told them there's no way. But I guess I really was. And when I started the plasma, I had to have someone come with me because I was in a wheelchair. I couldn't do very much at all, and I got depressed, and I didn't know what was going to happen with me. But I have to say that I've listened to Dr. Simpson and done what she's told me to do. I can't do everything I did before, but I have a very fulfilling life.
My name is Kelly, and I've been diagnosed with MG for about 5 years. If I would have known what I know now, I would have come to Houston a lot sooner. I wasn't diagnosed until about 4 years after I had the actual disease. I saw several doctors in Lake Charles, and they didn't offer me any kind of diagnosis. It wasn't until I came to Houston and saw doctors here that they were familiar with Myasthenia Gravis and were able to ask me the correct questions, and that helped open the door to so many things. I just appreciate Dr. Simpson and her staff and the fellows that work under her, and they were able to ask me the correct questions and get to a diagnosis. And I've been without symptoms for about 3 years now. And it's been great. I couldn't ask for a better doctor and a better way of life.
Hi, I'm Stacy Daigle, and I'm here to talk to you today about my journey with myasthenia gravis. I first started having symptoms a few days after I gave birth to my second daughter. I woke up, I was not able to brush my teeth, brush my hair. I had help getting dressed. And as the weeks, and months progressed, I actually started falling, and having trouble just, even walking across the room. And so after, a few months, I was able to get a referral over here to the Methodist neurology department. And I was able to get on, the path of getting treated. I started out, I had my thymus removed. I was on Cellcept, Mestinon. I was taking ivig every 2 to 3 weeks. And, I stabilized nicely with that regimen. And, of course, have had some bumps in the road over the last few years, but have managed to do well. I'm happy to say that at this point I am doing the best that I've ever done. I am just so excited. I can do anything with my family. I'm in the gym, I'm running, I'm doing things that I never thought I would do again. And so I'm just so happy, that I have made it to this point in this journey, and that I have, an excellent doctor and an excellent team, team around me who have gotten me here. So, just fight for yourself, find you good doctors, find you a good place, and, surround yourself with a good support system.
Hi, my my name is Yesenia. I've had
Anderson, and I am one of the general neurology and neuromuscular medicine faculty at Houston Methodist. Today, I will take a few moments to speak with you about how to navigate the emergency room should you ever need immediate care for a worsening of myasthenia gravis symptoms. This worsening is often termed a myasthenia gravis exacerbation. You will learn more specifics about a myasthenia gravis exacerbation and details on treatment options during this conference. We sincerely hope you or a loved one are never in a situation where you must use emergency services for any reason, including a worsening of myasthenia gravis symptoms. However, should the unfortunate situation arise where you need to go to the emergency room, we want to help you be as prepared as possible. An important step in being prepared for an unexpected situation is doing exactly what you are doing now, which is taking time to educate yourself and your family on myasthenia gravis. This knowledge will allow you to better identify and explain your symptoms to the healthcare team and be an active participant in your treatment plan. Also, you should have an updated list of all of your medications, including those you take for myasthenia gravis. This includes any oral medications or other treatments, including infusion therapies or plasma exchange. We recommend you keep this list readily available so you can provide this to the emergency healthcare team. You will also want to keep a list of medications that should be used with caution or avoided in patients with myasthenia gravis. This includes certain anesthetics, antibiotics, and antivirals. A list of these medications will be made available to you. So you may wonder when to go to the emergency room. You should go to the emergency room if you're having the following symptoms. 1, increased difficulty breathing. 2, increased difficulty swallowing. Or 3, progressive weakness, including weakness in your neck, which prevents you from holding your head up, or weakness in the arms or legs, which may prevent you from performing your typical daily tasks. If you are not sure what decision to make, you should always err on the side of caution and go to the emergency room. While you may want to contact your neurologist's office, do not wait on a response as to whether you should go to the emergency room. The response from your doctor's office may not be immediate, and time is of the essence. Furthermore, I can understand you may be concerned about going to the emergency room during the pandemic. However, wearing a mask, social distancing, using hand sanitizer, and limiting touching your face or other objects allows for the emergency room evaluation to be performed safely. Once at the emergency room, you will likely be seen by a triage nurse or other staff member. You will need to be specific about your symptoms and inform him or her about your diagnosis of myasthenia gravis. This will allow the team to better prioritize the care you need for your specific condition. Please make sure to also provide your home medication list. As part of your evaluation, the emergency room physician will perform an investigation to try to find a reason for your exacerbation. This will include looking for possible infection, such as respiratory infections, including COVID-19, physical stresses, such as a recent surgery or accident, or a new medication or exposure. Please be prepared to share any thoughts with the emergency room team about any recent changes or symptoms which may provide pertinent information about your situation. It is crucial that one of the first evaluations to have in the emergency room is bedside pulmonary function testing. Pulse oximetry or respiratory rate are not sufficient to evaluate your respiratory status. The 2 pulmonary function tests we focus on are 1, the negative inspiratory force, or NIF, or maximum inspiratory pressure, MIP, and 2, the functional vital capacity, or FVC. The NIF, which is also called the MIP, is a measure of diaphragm and accessory breathing muscle function. The normal value typically ranges between 70 to 100. We become concerned when this value ranges from -20 to -30. It is at this point we believe the diaphragm is too weak to effectively help with ventilation. The NIF should be measured both sitting up and laying down, as there may be a more significant reduction in this number when laying down. The FEC is a measure of your breathing status, looking at how much you can breathe out after breathing in. This is normally between 3 to 5 liters. When this number declines to about 2 liters or less, there is decreased ability to clear secretions and a weakened cough. If your respiratory function is a concern, we first want to try non-invasive ventilation, such as BiPAP or bi-level positive air pressure. This is a machine which uses air supplied by a mask over the face to offer respiratory support. We want to prevent intubation, but elective intubation may be considered if there's a trend of a decline in your pulmonary function testing, or if you are having more difficulty breathing. Your pulmonary function should be monitored regularly. In addition, your swallowing function needs to be evaluated to prevent aspiration, so food or liquid does not go into the airway or lungs. After these evaluations in the emergency room, you are likely to be admitted to the hospital for ongoing care, which will include management of any infections, any electrolyte disturbances, or the removal of any exacerbating medications or supplements. Medications should be chosen carefully, and if possible, all safe alternatives should be considered. In addition, you may be treated with intravenous immunoglobulin or ivig or plasma exchange. Once you are stable, it is at this point you or a family member should inform your primary neurologist about what has occurred. Near or at the time of hospital discharge, we recommend trying to make a follow-up appointment with your neurologist within 1 or 2 weeks. If an in-person appointment cannot be scheduled, please reach out to your neurologist to discuss your current health status and any potential next steps. This may be a lot of information to retain, so an emergency checklist for myasthenia gravis emergencies has been provided with an outline of the points of this talk. I want to stress the importance of this information, not to scare you, but to empower you. You are your best health advocate, and being informed is a crucial part of improving your quality of life. Our speakers today are experts in their field and are ready to provide you with valuable information. I want to thank you for your attention and being an active participant in this conference. Hello, everyone.
My name is Yesenia. I've had MG for 11 years, since I was 19 years old. When I was first diagnosed, I was in my undergrad, so it was my first time living by myself, and it was a little scary. And when I went home to get diagnosed, shortly after I had a thymectomy. After my thymectomy, after a few years, I started IVIG treatment, which I would get once every 4 weeks for about 5 to 6 years. And when I was 26, we decided to start a different treatment because IVIG was just not as effective as we'd hope. And I started Imuran, and I couldn't tell right away, but I was able to tell later on that it was working. And I'm able to do more now than I was in the past. Some of my first symptoms were my facial features. I couldn't really talk or eat or close my eyes all the way. I still have some weakness around my mouth at times, but not to the extent that I can't talk or eat, which is really good. A few years after, I started experiencing general myasthenia gravis, which was throughout my entire body, which was weakness in my legs and my arms. I couldn't dress myself. I couldn't do my makeup. I couldn't do my hair. So it was very frustrating because I was in school. But the treatments have definitely helped, and I guess the years of knowing what does affect my myasthenia gravis and what doesn't helps. Like if I knew back then that the weather and stress affected me as much as they do, I would have probably done things a little differently so that I wouldn't go into crisis modes. And also my support groups, you know, being able to speak to someone that has MG has definitely helped to be able to speak to someone that understands exactly or close to exactly how you feel with the symptoms and the medications and side effects of everything has definitely helped.
Hi, I'm Joy, and I'd like to share with you some of my experiences since developing myasthenia gravis. About 12 years ago, I started feeling tired and not having a lot of energy. And so I went to my family doctors, and they all said, well, you know, you're a single woman, you're depressed, you're overweight. Well, I felt that there was something more than that. So I came to Methodist and found Dr. Erica Simpson, and my world has changed. Dr. Simpson had listened to what all I had to say, and then she had me walk down the hall, and I believe at that point she knew what I had, and then followed up with a test to prove it. After that, she started prescribing medicines for me, and I have to say, I was upset about how many pills I had to take because I thought only old people took that many pills. But the pills began to help. I also started with plasmapheresis. And between my pills and plasmapheresis, that has been my treatment for the last 12 years. At that time, I was not able to move my neck very much. I wasn't able to do the things that I'd always done. They tried to tell me I was a type A personality, and I told them there's no way. But I guess I really was. And when I started the plasma, I had to have someone come with me because I was in a wheelchair. I couldn't do very much at all, and I got depressed, and I didn't know what was going to happen with me. But I have to say that I've listened to Dr. Simpson and done what she's told me to do. I can't do everything I did before, but I have a very fulfilling life.
My name is Kelly, and I've been diagnosed with MG for about 5 years. If I would have known what I know now, I would have come to Houston a lot sooner. I wasn't diagnosed until about 4 years after I had the actual disease. I saw several doctors in Lake Charles, and they didn't offer me any kind of diagnosis. It wasn't until I came to Houston and saw doctors here that they were familiar with myasthenia gravis and were able to ask me the correct questions, and that helped open the door to so many things. I just appreciate Dr. Simpson and her staff and the fellows that work under her, and they were able to ask me the correct questions and get to a diagnosis. And I've been without symptoms for about 3 years now. And it's been great. I couldn't ask for a better doctor and a better way of life.
Welcome back to our Patient Education Conference, 12th Annual Conference, Myasthenia Gravis. So our next speaker is Dr. Ashley Anderson. She's an assistant professor of neurology here at Houston Methodist, a neuromuscular specialist. She received her medical degree at Morehouse Medical College, then went on to the University of Florida in Gainesville, where she did neurology residency, and we were privileged to train her as a neuromuscular fellow, and she joined our group. She's going to talk about the management of acute exacerbations in crisis. Dr. Anderson, welcome.
Thank you, Dr. Green, for that introduction. So hello and welcome, everyone. Thank you for joining us for the 12th Annual Myasthenia Gravis Conference. I am here to provide you with some information and guidance in regards to the evaluation and management of exacerbation and crisis in myasthenia gravis, mostly directed toward the patients and their families. Before we get started, I would like to take a brief look into the history of myasthenia gravis. So this condition was first described in 1672 by Dr. Thomas Willis regarding a patient that he describes as the following. He says, "At this time I had under my charge a prudent and honest woman who for many years hath been obnoxious to the sort of spurious palsy, not only in the members but also in her tongue. She for some time can speak freely and readily enough, but after she has spoken long or hastily or eagerly, she is not able to speak a word, but becomes mute as a fish, nor can she recover the use of her voice under an hour or two." So we consider this kind of the first description of myasthenia gravis that we see in the literature. Then it was approximately 200 years later when Dr. Samuel Wilkes described this condition in a female patient that presented with slowed movements and difficulty speaking, which he described as a bulbar paralysis. However, it was not until around 1895 when Dr. Friedrich Jolly coined the term myasthenia gravis after he evaluated two teenage boys who had fatigable weakness, and he did so by combining the Greek word for muscle weakness with myasthenia and the Latin word gravis, meaning heavy or grievous. And so I mention all of this history to say that while the identification of myasthenia gravis is not new, the advances in the diagnosis and management of myasthenia gravis had made it so where it is not so much the grievous condition it used to be. While it is still a serious condition, I hope that that message comes through here with the talks today, that there is treatment available and that there is definitely more on the horizon in regards to effective treatment. So today, the objectives of my talk are first we're going to define myasthenia gravis exacerbation and crisis, look at the certain signs and symptoms which are involved, look at potential provoking factors and triggers, different types, what we do for an evaluation as well as management, and then look at the prognosis should you have a exacerbation or crisis, and then how to prevent it. So as we move forward with this talk, it's important that we define what we are discussing. So sometimes the terms myasthenia gravis exacerbation and crisis are used interchangeably, but they are distinct and may be managed differently. When we talk about a myasthenia gravis exacerbation, this means any worsening of an MG symptom or symptoms, and this can range in severity. And so this can include worsening of ptosis or eyelid droop, worsening of blurry vision or double vision, and can extend into worsening of issues with speech, swallow, weakness, or breathing. And it can be very mild to more severe, to where the exacerbation can result, unfortunately, into a crisis. And this is described as an exacerbation that results in respiratory failure, which requires ventilatory support, such as a BiPAP or mechanical ventilation through intubation. Now, this occurs in about 15% of patients that have myasthenia gravis, mostly in the first 2 years after symptom onset. For about 20% of patients that have a diagnosis of myasthenia gravis, a myasthenia gravis exacerbation or crisis may be their initial presentation. So when we look at the different signs and symptoms which may be associated with a myasthenia gravis exacerbation, we can see several things that could be involved. One could be ptosis, and this may be asymmetric. So meaning one eyelid may be more droopy than the other or more affected, and that's not uncommon. Patients may also experience some issues with what we call some ophthalmoplegia, meaning some weakness with their eye movements as well. They may also have some issues with neck weakness, including neck flexion weakness or neck extension weakness, which results in head drop. There could also be facial weakness that can occur in the eyes, in the cheeks, and around the lips. This could result in issues where there's more persistent drooling, difficulty to puff the cheeks, difficulty to close the eyes fully. Patients may also experience blurry vision or double vision. And typically here, again, just like with myasthenia gravis, it's going to be better at the beginning and worse towards the end of the day. But as for an exacerbation, this may become more persistent if a patient's experiencing an exacerbation. There may also be limb weakness or fatigability, and what may be seen here is may experience more difficulty with rising from a seated position or difficulty with raising arms. Oftentimes we see more proximal muscle weakness when we talk about myasthenia gravis weakness, which means more shoulder or hip weakness. There may also be more fatigability in that tasks that did not cause issues with fatigue or tiredness may now do so. What we also get concerned about is issues with difficulty speaking, which is termed dysarthria. And we evaluate this looking at both sometimes associated with tongue weakness, with palatal weakness, with kind of mouth just weakness in general that can occur, then difficulty swallowing. What you may see here is kind of goes on to the next one as well as some either it looks like increased saliva, but maybe more difficulty just clearing your secretions, swallowing the secretions. And then you may notice difficulty initially just to liquids, which may progress to difficulty with swallowing solids, more thicker foods as well. And then shortness of breath, also termed dyspnea, may occur. And this can occur with activities, and we get concerned when activities that would not usually make you short of breath now are making you short of breath. And then also there may be an inability to lay flat due to shortness of breath, also termed orthopnea, that we may see as well. So when we talk about excuse me, just gonna get back here. All right. So when we talk about an exacerbation or crisis, we try to identify a particular cause. And so for the vast majority of cases, a provoked cause is identifiable and usually is either infection, it could be a recent surgery, trauma, accident, or a certain type of medication that was recently introduced. There was a 2018 study, which you're seeing here, in which that was performed to evaluate the most common causes of a myasthenia gravis exacerbation. And as we can see here, two of the most common ones here are what they've termed VPI and VNPI, which stands for the first one, vaccine preventable infections. And so these include things like the flu. And then the second category here, vaccine non-preventable infections, and these include things like a urinary tract infection. Then after that, we see another common contributor here was found in this study is the use of, and as they've termed here, is medications to avoid or use with caution in patients with myasthenia. And in the next slide, we will go over what some of those medications may be. There are some other different potential causes here, including just social life stressors and having different types of treatment, a different procedure that may have preceded the exacerbation. And so we look at different types of medications that are used with caution or should be avoided in patients that have myasthenia gravis. And this is just a kind of a partial list here, but hits the important highlights. And so beta blockers used for heart or your blood pressure control, What we get concerned about oftentimes is certain types of antibiotics that are used. And if you have an infection, we definitely recommend talking with your provider about letting them know your history of myasthenia gravis and either provide the doctor or have the doctor look up what medications are acceptable or should be avoided to treat that specific infection. Now, we do come across situations in which patients can only have a certain type of antibiotic to treat that particular infection. And in that particular case, we recommend treating the infection and that patient having very close follow-up with both their provider who's giving the antibiotic as well as their neurologist to evaluate for any signs of exacerbation. You may also see on here corticosteroids, so things like prednisone, and actually steroids are a mainstay in myasthenia gravis treatment. However, there is some evidence that high doses that are given rapidly or started at a very high dose may cause some mild worsening of myasthenia gravis. And so we will talk a little bit more about dosing of this, or what is recommended for patients with myasthenia. So as part of the evaluation for when you're experiencing a myasthenia gravis exacerbation, you want to get a good history. So you want to let the providers know when the symptom onset was, even when you were diagnosed with myasthenia gravis and what type of symptoms you had at the time you were diagnosed. And of course, what types of symptoms you are having now and what your current treatment regimen is for your myasthenia gravis. Then there will be an evaluation to identify or evaluate for any kind of provoking factors, what we went over in previous slide. It's also important that you have a swallow evaluation. Even if you don't think your swallowing is impaired, it's important that this is evaluated so that we're reducing the risk of aspiration. Again, very importantly is having the bedside pulmonary function testing. And as you have already heard, so I won't go into extensive detail about this, but it's important to not only get just looking at the oxygen level, as we know that that is not an accurate measure of the respiratory function in patients with myasthenia, but also looking at their diaphragm function, which is measured using what is called the negative inspiratory force, or the maximum inspiratory pressure, and then also looking at the functional vital capacity. We already talked about kind of what normal is and what we're looking for. Now, sometimes your provider may perform, if these tests aren't readily available, what's called a single breath count. This is a quick bedside evaluation in which your provider may ask you to take in a deep breath and then count out loud as high as you can on that one breath. What the cutoff is of where we get concerned is at 20, and that because that represents approximately a functional vital capacity of around 2 liters. Now, not all exacerbations need to be seen in the hospital or evaluated in the emergency room. If there's minimal or mild exacerbations, including those that involve ptosis or vision changes or some mild extremity weakness, these may be able to be handled on an outpatient basis. What's going to happen is, again, we're going to make sure we get some good history from you as to what's been going on and possible provoking factors. And then either a virtual or an in-office visit may be scheduled. Now, in this era of COVID, virtual visits have become more of the norm, and just rest assured that virtual visits can still provide your doctor with the information that he or she needs to appropriately evaluate your situation. They can hear your voice and whether it's seeing more slurred or nasal sounding, see how you're breathing, whether you have to take a lot of pauses as you're talking, and have you perform different types of maneuvers or tasks to evaluate your strength. Based on what is seen there, Certain adjustments may occur to your treatment regimen, which may be to your pyridostigmine, which is also called Mestinon. The typical dosing for that is usually around 60 milligrams 3 times a day, but during the times of an exacerbation, either increased dose or increased frequency is not uncommon. However, we want to make sure that we're not increasing the dose or the frequency too often, and make sure that you do not try to self-increase the dose of your Mestinon unless discussed with your neurologist, as taking too much Mestinon can lead to something called a cholinergic crisis, which can cause actually worsening of the weakness, more secretions, more issues with saliva, more issues with muscle fasciculations or twitching, vomiting, diarrhea, etc. If you're not already on prednisone, your doctor may prescribe prednisone, and we'll talk about some issues with the dosing a little bit later. Or if you're already on prednisone, the dose may be increased by a certain schedule. Or your doctor may decide to try to start you on IVIG or plasma exchange, or adjust your schedule of those given if you're already on that. However, there is still a low threshold for going to the hospital or the emergency room if there's any symptom worsening. Now, for more moderate to severe exacerbations, these are ones that we are concerned about when there's progressive worsening in the swallow or with breathing. This requires immediate presentation to the nearest emergency department. Now, if your neurologist works at a hospital or clinic that is not close to you, it is important that you don't try to wait or drive to get to that particular location, that you go to the hospital that is nearest to you so they can evaluate respiratory status. Once that is evaluated, then you will likely be admitted to either an IMU, which is an intermediate care unit, or the ICU. At that point, any possible contributing medications, including the pyridostigmine or Mestinon, may be discontinued, as the Mestinon may increase secretions, which would make it more difficult as far as managing respiratory status. You will get regular monitoring of your breathing, and that is through looking at the NIF or MIP, as well as the FVC. This is usually done every around 4 to 6 hours to evaluate, to make sure you get that the evaluation is regular, but also not so frequent that it just causes more tiredness and weakness. Should there be evidence of some respiratory compromise, the first step, as was previously mentioned, is the use of non-invasive ventilation through the use of, for example, for a BiPAP. However, sometimes if there is prominent what we call bulbar symptoms, so issues with managing secretions, having severe issues with your respiratory status, intubation may be considered. And then it's also important, and you'll be in the ICU, that you have cardiac monitoring, as some patients with myasthenia gravis exacerbation and crisis may have certain heart rhythm irregularities. So how we manage the exacerbation is to 2 treatments that are primarily used, which the first is intravenous immunoglobulin, or IVIG, and this is purified pooled preparations of the IgG antibody from plasma of multiple donors, and it works through several different mechanisms to modify the immune system. Typically, this is dosed as given 2 grams per kilograms of the patient weight divided over the course of 4 to 5 days, and this is given as an infusion through the peripheral IV. The next commonly used treatment is going to be plasma exchange. It's maybe termed PLEX, it may also be termed as plasmapheresis or apheresis. This works by directly removing the antibodies, and we can kind of call the myasthenic antibodies the bad antibodies, from the circulation. This is usually done as 5 sessions scheduled every other day, but this one may require the placement of a central venous catheter. Now, while both of these treatments are typically very well tolerated, there are some different risks or cautions that we have to use and some different side effects that may occur. So for the IVIG, we want to use this with caution in patients that have certain cardiac and vascular histories, including patients that have a history of a DVT or a blood clot that happened either in the legs or in the lungs, and patients that have issues with kidney disease. The most common side effects of IVIG are going to be headache. You may also have issues with chills or body aches, but otherwise it is very well tolerated. And then with plasma exchange, we use this with cautions with patients who are at risk or have an infection. And the reason why, as I was mentioning previously, we're doing this to remove those bad myasthenia gravis antibodies, but along with that, there's sometimes indiscriminate washing out of some of those good antibodies that help to fight off infection. And then patients that are at high risk of bleed, there's also use and caution for this, as the plasma exchange can also wash out certain clotting factors that are required. And again, this may require the placement of a central venous catheter, and that is a procedure, usually very well tolerated and brief procedure there, but some complications may occur. So, excuse me. So in looking at the effectiveness of either IVIG or plasma exchange, there have been several studies performed, and they both have a similar effectiveness in regards to clinical response. However, in the vast majority of cases, plasma exchange may be used first as it has a more rapid effect. However, plasma exchange is not as readily available as IVIG, and as mentioned before, does require, for example, possible venous catheter placement. If there is incomplete clinical response from plasma exchange, then IVIG may be given subsequently, which is common, and exactly what treatment is used during the time of an exacerbation or crisis really depends on the patient characteristics and safety and tolerability, previous response if there was an exacerbation, and other patient-specific factors. Now, the use of steroids. So the use of steroids in myasthenia gravis is extremely common, and as I mentioned before, one of the mainstays in regards to the treatment of myasthenia gravis in general. The use of steroids is often a major part of the treatment plan for an MG crisis. As I briefly mentioned, we're talking about medications to use with caution. The rapid administration or the high dose steroids may cause a brief worsening. Now, this is much less likely to occur in patients who are being treated with IVIG or plasma exchange. And so depending on the symptoms and other factors, the starting dose and the goal dose can vary. And so for our patients who are having an exacerbation but who are not intubated, so who are either not on any ventilatory support or are using a non-invasive ventilation such as BiPAP, we usually want to start lower, usually around 10 to 20 milligrams, and then increase by 5 or 10 milligrams or so over the course of a few days. Usually the goal is around 60 to 80 milligrams per day. And our patients who already have ventilatory support through mechanical ventilation and intubation, much higher doses can be tolerated. As mentioned before, your provider may decide to start prednisone for you if you have a minimal or mild exacerbation, and usually these doses, again, are started lower on the outpatient setting, around 10 milligrams, and then increased about 5 to 10 milligrams every week to 2 weeks, and then, of course, there may be this what we call transient worsening that may occur, meaning that your symptoms may get a little bit worse before they get better. Now, this should be very mild and only last a few days. Should their symptoms last longer or be more severe, this is when either you present to the hospital, depending on the severity, or contact your provider to let them know what symptoms you are having. So in regards to the prognosis of myasthenia gravis exacerbation, the vast majority of patients who suffer a myasthenia gravis crisis will make a full recovery. which is great news. Now, complications can occur from a prolonged hospital stay, ICU stay, or with intubation. And what we see here is that the risk factors that are typically associated with more prolonged hospital stays or a slightly worse outcome are things like having to be on ventilation for a longer period of time, which is described as 15 or more days, patients who have later onset myasthenia gravis or who were diagnosed at a later age, patients who are of an older age, or patients who have multiple other medical comorbidities. And infection was a primary reason for these certain complications, but as mentioned, the vast majority of patients make a full recovery. So then is how do we prevent this? So we don't want you, of course, to have an exacerbation or crisis. And so the first thing is early and accurate diagnosis. And so we want to make sure that we're seeing the patients that have symptoms that may be suggestive of myasthenia gravis are seen by a specialist soon after the symptoms start, so that a diagnostic evaluation can be performed and that we can make sure we get an accurate diagnosis. Then patients also need close outpatient monitoring, especially early in the disease course. As mentioned earlier in the presentation, patients are more likely to have an exacerbation or crisis in the first 2 years after symptom onset, so we want to make sure we see those patients more often. And then doing exactly what you're doing right now, which is getting educated on early identification of certain symptoms which may be associated with an exacerbation. And then treatment, getting on the appropriate treatment plan and making sure that you're followed closely with your neurologist. And treatment adjustments may need to be made. There is not a one-size-fits-all treatment plan for myasthenia gravis, and I'm sure as many patients out there with MG know, MG affects each patient differently. And so as you and your neurologist learn your MG, different treatment adjustments may need to be made. And then again, management of other medical conditions or comorbidities in order to kind of help your overall health. All right, and then lastly, vaccination. And so I know that we're going to talk more at the end of the conference here today about COVID-19 and vaccination, but it was also previously mentioned in the earlier talks about the importance of vaccination for vaccine preventable infections, as was mentioned in a previous slide for things like flu, as well as pneumonia and COVID-19. And so I will conclude my talk today with just a brief picture here of what I call the kind of the checklist for a myasthenia gravis emergency. You may be able to find these on the Myasthenia Gravis Foundation website, or different variations of this. But it goes through just kind of briefly what you should be aware of or have with you or discuss with your emergency room provider should an exacerbation occur, such as making sure to have a list of all, updated list of all medications and treatments, including who your physicians are. You make sure to try to keep a list or advise the provider about medications that should be avoided or used with caution in patients that have myasthenia. Make sure that everybody in the room, in the emergency room, and your providers are aware of your diagnosis, any recent changes that have occurred, including medications, surgeries, any signs of infection. We already talked extensively about the importance of getting the pulmonary function testing and getting your swallowing evaluated. And then talking about here as far as treatment here with IVIG or plasma exchange. Your treatment team should include a neurologist as well as a pulmonologist. And then you can, while all this is going on, you can contact your neurologist and let them be aware of that, but do not wait for a response from your neurologist before seeking emergency care. And then you want to make sure that you have close follow-up with your neurologist after discharge, so any treatment adjustments and follow-up can occur in regards to your symptoms. All right,
I want to thank everyone for your attention today. I hope this has been informative, and I'm willing to take any questions. Thank you so much.
Thank you, Dr. Anderson. We actually have a number of questions, some of which disappeared because of the number of questions just that's in the chat.
Sure.
So one of them was the role of stress. And one attendee asked, what's the role of stress? Can it worsen myasthenia gravis?
So as was seen in one of the previous slides in the 2018 study that I mentioned earlier, stress was actually one of the factors that can worsen myasthenia gravis symptoms. Life stresses, social stresses, in a medical terms, and kind of increases the inflammatory responses that can happen, and again resulting in kind of this immune reaction, and we can see patients that have a worsening of their symptoms as a result.
Okay. Another question that came and disappeared was a patient is wanting to know, is there an objective test that can tell them that they're worsening? How do they know that they're worsening?
That's an excellent question. So we use, in the office, so for more of a long term, we use several tools. So there is an MG ADL tool, and there's an MG quality of life tool that we use, which are certain questions. So the ADL tool stands for activities of daily living, and it asks things, for example, about your speech, swallow, your breathing status, any issues with eyelid droop, etc. And it asks about, on a scale of, I believe it was kind of 0 to 3, whether or not these are getting worse. And this is more looking so over time. And then quality of life scale. We're interested in making sure that we're not only treating you just to get rid of your symptoms, but also to improve your quality of life. And so this asks about things about, do you rely on others? What's your social skills or experiences like? And we can see over time whether or not, based on the treatment that you're receiving, whether or not this gets better or worse, and then treatment adjustments can be made. Now, in the more short term, for example, with an exacerbation or a crisis, that is based on kind of where you start. So it's hard for me to say exactly, but if you know, for example, you could take 20 steps and you did not get short of breath, and now you take 20 steps and you're feeling very tired or you're getting more short of breath, then we qualify that as a worsening or an exacerbation, and this is something that you need to let your neurologist know.
Okay. We do have a question that I can post.
Yeah, so great question. So plasmapheresis is effective for seronegative patients. So when we say a patient is seronegative, it doesn't mean that you don't have an antibody that's associated with your symptoms. It just means we haven't found it yet. We can only kind of identify what we have the tests for. And so as I'm sure was seen earlier, there's many proteins and that are involved in the neuromuscular junction and the pathogenesis or the development of myasthenia gravis, and we just haven't discovered it yet, but plasmapheresis can be an effective treatment.
And the last question, I'm not posting it because it has about 4 or 5 topics in it, but the one that I think we can talk about is the question of antibody fluctuations with the disease. Okay, I'll post it, but we'll concentrate on the first part. Let's see. All right. And so I'll let you take the antibody fluctuations.
Let's see here. Let's see. So there's a question I've had about antibody, when antibody levels fluctuate. So when we diagnose a patient, so when we're looking at antibody fluctuation, when we're diagnosing a patient with myasthenia gravis, how we look at that is whether you come back, if we're talking about antibody positive myasthenia gravis, whether you come back antibody positive or antibody negative. Really, the levels of the antibodies do not have been shown time and time again in different studies and just in our basic clinical practices to not necessarily correlate with the severity of disease, if that is the question. And so I'm not sure how often these antibodies may be getting tested that showing the different fluctuations, but if you're positive, and you have that antibody, and we treat accordingly for myasthenia gravis.
So I agree with you. I think for acetylcholine receptor antibody, which is the most common antibody, the levels of the antibody do not correlate with the disease. We've seen patients who have very low positive numbers but are very clinically affected, and we've seen patients with titers that saturate the test. We can't even detect them, and they're very mild. The exception with that is the MuSK antibody, which is an autoimmune myasthenia, but as Dr. Schroff mentioned, it is different. It's more aggressive, and even its character is different, the type of antibody that it is. Those tend to correlate, and so they tend to go up when the disease is bad, and they tend to go down when the disease is better. So we do see that as well, but that's about it. And thank you. Thank you so much, Dr.
All right.
Anderson.
Thank you.
Wonderful. We are so enjoying all of these wonderful questions. I will say some of the questions which we want to answer, we may not be able to answer in the live talk, but we are trying to respond to you in the chat so that you know that we did note your questions. Of course, some of you have asked for personal recommendations. As we are not your physicians, we can't give specific recommendations, although, you know, we can definitely give general recommendations, and we will try our best. We're hopeful that you'll take this information back to your treating physicians and have discussions, and hopefully that will help guide your care. Our next speaker is Dr. Sheetal Shroff. She is a neuromuscular specialist who did her residency in Texas, University of Texas in Galveston, and like Dr. Anderson, was a fellow in neuromuscular medicine in our program several years ago. She has joined our department, is a partner in many of our clinical trials. She is a primary investigator in clinical trials in myasthenia. She also does the Electro diagnostic testing that many of you have experienced in your own journey with MG, and she is an excellent clinician and teacher. Dr. Schroff will be talking about the practical approach. How do you navigate the emergency room? And she's going to talk to you from the perspective of what an emergency room doctor sees and does, and also from the perspective of the neurologist. Dr. Schroff?
Thank you, Dr. Green. Okay. These are my disclosures again. So these are some of the, I have just listed a few, what patients, like have told me and we have discussed, saying I was in the hallway waiting for 2 hours. The nurse told me my O2 sats were normal, so my breathing was fine. And then some say I'm afraid to go to ER because they think I'm drunk, or I'm worried the ER doctor might not know or might not be aware, of myasthenia or how to manage myasthenia. So these are all the different responses or experiences which, patients have told or come across. So again, recognizing the clinical features is important. Like we went through, and I know Dr. Anderson, went through the symptoms again with the ocular symptoms, the fatigue, the muscle weakness, speech involvement, slurred nasal intonation, swallowing, choking, nasal regurgitation, shortness of breath. So these are all the different clinical features of myasthenia gravis, and then I'm not gonna repeat these. If one has MuSK MG, then it's more of like bulbar speech, swallowing, breathing involvement versus acetylcholine receptor antibody MG. It's more of generalized weakness, but they can as well have some speech and swallowing and ocular involvement as well. Now, normal respiration, just to know what happens. So for normal respiration, we have inspiration and expiration, means breathing in and breathing out. Breathing in is basically done by the diaphragm. Okay, that's the major muscle. And then we have the chest wall muscles and the neck muscles, which kind of help or assist the diaphragm muscle. So breathing out, which is expiration, it kind of happens like an elastic band when it is stretched, and then when you let go, it kind of recoils back. So that's the same way your lungs, when it is expanded, when you breathe out normally, it just recoils back like an elastic and gets back into the position. So unless you have to push the air out forcefully, that's when, again, we use some of the chest wall muscles and then as well as our abdominal muscles. Now, as you can see here, normally when we breathe, we don't use our neck muscles and a whole lot of chest wall muscles. But if one sees that there is, like this sucking in or like lifting up of the shoulders and using even the neck muscles to breathe in, then that means they are kind of using their accessory muscles to kind of help diaphragm to take the full breath. And sometimes we also see like patients who are like hunching their back and kind of like bending over. We call that as a tripod position, basically to kind of get a better breath. So these are some things, to look out for. And the next thing is, your body the best. And it's important to kind of establish a baseline. So not every patient has their own has the same baseline. Like for example, like at my best, like what do I have any symptoms? And or say you have had a long day or a stressful day, then what are the symptoms, like which you might notice at the end of the day? Typically, like for some it might be an eyelid droop, and for some it might be a double vision. For some it might be just tiredness, or some it might be change in the speech at the end of the day. So it's good to always establish a baseline and know what are the symptoms one might get. And the next is, if one has had previous exacerbation or a flare, what symptoms got worse? So that's also important to kind of know. And also, when you first presented with MG, what was your symptom? Yes, some patients present only with eye or ocular symptom, and then it gets generalized. So that's it. Then that becomes different. It's during flare, all these symptoms might get worse. Next, does your symptom fluctuate day to day, or it's only like, say, only in summer months, like I see these symptoms, or only under stress, like I see these symptoms. So it's kind of good to know how your MG behaves, and then kind of establish a baseline. And some of the precipitating factors which can lead to MG exacerbation are like infection, surgery, poorly controlled MG, certain drugs, and sometimes the cause is unknown. It just, the exacerbation happens out of a blue. Okay, so then what is myasthenia exacerbation? So here it's worsening of some or all of the muscles, but there is no need for invasive assistance for breathing, as in like intubation. And it can be managed with the use of non-invasive ventilation like BiPAP or breathing machines, AVAPs, and things like that. Again, this varies in each patient: speech, swallowing, droopy eyes, double vision, and usually it develops over a period of days or to a week. I think this is, spelling mistake, okay. If left untreated, then it can progress to crisis. So crisis means there is respiratory failure. I know we went over this. So what are the signs of impending respiratory failure? So some of the signs are inability to raise the head, that means like head drop, and also use of like these accessory or neck muscles to breathe. And there is something called as paradoxical breathing. So that means when we lay down and then, as you can see in this picture, Normally, when you lay down and then take a breath in, both your chest and your belly, abdomen has to move in the same direction. That's normal pattern. But if there is diaphragm weakness, then when you take a breath in, then the chest goes up, but then the abdomen sinks in, or like it goes down. So this is called as paradoxical breathing. And I'm going to come to that. There's a little video there. I'll come to that. And also the inability to count in a single breath up to 20. So again, it's, so I'm going to show you two, or like, demonstrate two scenarios. So again, counting till 20, there's a caveat to it. I can count like this. 1, 2, 3, 4, 5, 6. Okay, that's less than 20. But I am not in respiratory failure, So, and then, so there is a speed and a rate at which we have to count those numbers and then try to exhale, in a controlled manner. Only then, you can really assess that single breath count, and then it can be much more valid. Worsening generalized weakness, slurred speech, or choking when swallowing, and also ICU monitoring for respiratory support and elective intubation might be required, for patients with myasthenic crisis. So let's see if this plays. Yeah. So this is a video clip I have borrowed from an article. So here the patient, you can see the paradoxical breathing, the movement of the chest and the abdomen, where the chest goes up and the abdomen goes down, and he seems to be in respiratory distress, struggling to take breaths. Okay, so when your MG symptoms get worse, you do need to inform your neurologist immediately. So emails and MyChart messages are not the best way to communicate when things get worse. I have had patients, sometimes say I have sent 6 MyChart messages from Friday afternoon till Monday morning and haven't gotten response to that. So I wouldn't, recommend sending MyChart messages or emails. When things get worse, then call, pick up the phone, and please call and speak to a nurse, or there is always an on-call neurologist. It might not be one of us or your neurologist who is on call, but there is always a neurologist who is on call who you can speak to in person on the phone. So that's what I would recommend if things were getting worse. So some of these assessments you can do at home, mainly if you're having to take more than 25 breaths per minute. That means you're short of breath. Again, muscles around the neck and abdomen are pulling in. You can't speak full sentences in a single breath, and you have head drop, weak cough. So these are all the symptoms, or to kind of do a quick assessment, either your family member or, yourself if possible. Pulse oximeter, it's not helpful to assess the respiratory muscle weakness. By the time the pulse ox falls or shows low number, it's too late. And again, it does not tell anything about carbon dioxide. Again, single breath count is something, you can always kind of do to assess. And then keep the temperature cool, head end elevated, call EMS or 911. If you have a breathing machine already, then put it on and then be on the breathing machine, and then head to the ER. There are text to 911 available in some places if speech is impaired and you cannot talk, so that's something you can do. And again, what to take to the ER. I know Dr. Anderson gave a thorough checklist, which is available. So these are all the things I would say, contact information of all your physicians, emergency contact list, MG information to providers. If you have the cautionary drug list, your medical history, hospital records, all your complete list of medication, health insurance card, if you have any implanted devices, and also your breathing machine. So that's very important. Not all ERs and hospitals have, if you have a Trilogy or a AVAPs, not everybody carries those machines. So whether you need it or not, pack your breathing machines and take it with you. If they have, they can always copy the settings from that. If they don't have it, then you can use yours. So this is one of the MG cards which is available on MGFA, and we have another card which we give in our clinic, which basically tells, you know, your name of your neurologist and says, you know, the symptoms which you can have and the cautionary meds, and it's kind of helpful for your first responders to assess promptly. So how do patients usually present to the ER? So there are three, these are the three most common ways, you know, which they can present. A stable MG patient, mainly for a completely unrelated issue, like say, you know, like there's, they develop appendicitis and then they come to the ER, or a gallbladder issue, or gastroenteritis. So their MG will be fine, but then they're in the ER for a completely different reason. So that's one of the most common presentation. The second most common is MG exacerbation, where MG symptoms, you know, get worse. And rarely we do see undiagnosed MG presenting with all the symptoms of like speech, swallowing, drooling, respiratory muscle weakness, presenting to the ER for the very first time as an exacerbation. That can happen as well. So it is important, you know, like in those instances for the ER physician to assess take a good history, examine the patient, and then, you know, like, and get a neurologist on board. And again, these are the list of drugs. It's important because some patients can develop with cardiac manifestation, arrhythmia, chest pain, and then cardiologists might get called in first, and then, you know, if they use any of those antiarrhythmics, then in MG patient where MG may be completely stable, then it can still, you know, precipitate MG exacerbation. So in the ER, so not all ER physicians know about MG or manage MG on a regular basis. MG is a rare disorder. It's not common. And then not all ER or hospitals have neurologists who manage MG as well. So you are your biggest advocate, and it's extremely important, you know, to communicate and, you know, like be your advocate. Educate your family members about MG so they can speak for you if you are not able to speak in the times of MG exacerbation. And again, communication with the ER physician and your neurologist is crucial. In the ER, usually, in addition to the blood work, pulmonary function assessment, I know Dr. Anderson went over this. We call it the NIF, the vital capacity. Bedside test is the single breath count, and do not rely on pulse oximetry reading, especially if you are having breathing difficulty and the pulse oximeter shows normal. And elevate the head end of the bed to reduce aspiration and work of breathing, and also use of the breathing machine should be initiated promptly and as soon as, you know, one reaches the ER. And also secretion or like suction. Sometimes, you know, there may be drooling, pooling of secretion, so always, you know, it's good to have suction assistance with you. And again, you know, I have mentioned, I know I'm repeating it a whole bunch of times about pulse oximeter because we have heard numerous times that, you know, yes, I have been told I have normal O2 sats, so my breathing is fine, you know, so that's why I'm repeating and stressing it multiple times. And, you know, workup for blood work, infection, it could be UTI, upper respiratory infection, COVID, pneumonia, electrolyte abnormalities, and also, you know, getting an arterial blood gas. Again, it's a blood work where they take the blood from the artery and check for the level of oxygen, carbon dioxide. is a much more reliable test which can be done in the ER, and that kind of gives a clear picture of what is going on in regards to breathing status. Chest X-ray and CT chest also looking for infection can also be done. So once patient is stabilized, then treatment of these unstable myasthenic patients require neurologist and also ICU care and availability of IVIG and plasma exchange. So if these resources are not available in that particular hospital or emergency room, then the patient should be stabilized first, and then the patient should be transferred to the closest or the nearest hospital or a facility where they have all these availability or the treatment options. So during the transfer as well, a patient should be closely monitored, and then in case something were to happen, ability to initiate non-invasive or intubate or intubation should be available even during the transfer. So this I included, just as an inpatient, probably not for ER, just, like even as an inpatient when you're admitted, how your nurses can help, like, taking shower, having rest period, like, before and after shower, or adjusting, taking your medication, especially the pyridostigmine, before any kind of activity, like if it's physical therapist, or eating, to kind of improve the symptom and help you getting speech pathology. And then even in diet-wise, the ones which are easy to chew and swallow, thickener, small bites, and things like that, eye patch for double vision. So these are all the things which your nurse can help with. So from the ER, some patients might have to go emergently to surgery. There's no time to wait. Say there is they come with like intestinal obstruction and there's a perforation and they need to undergo surgery. There's no time to wait. Their MG symptoms, seem to be pretty well controlled. So in those instances, you have to make sure to tell your surgeon and anesthesiologist that you have MG. And then pyridostigmine can be changed from oral to IV form, and then a baseline pulmonary function test has to be done, even though you don't have no symptoms of shortness of breath, it still needs to be done. And you might need the non-invasive like BiPAP or any kind of breathing machine post-operatively, because you might take longer time to recover from the anesthesia. So these are some of the things which your surgeon and the anesthesiologist have to be aware of before they take you or take the patient into the surgery. And again, it's best if it's done for elective surgery first case of the day, to reduce the amount of time. One is NPO or nothing by mouth. And then post-operative monitoring, and some patients might need plasma exchange or IVIG before or after the surgery. And also for anesthesiologists, it might be important because they might need to use certain reversal agents to reverse the effect of anesthesia if it's taking too long or the breathing is being compromised because of anesthetic agent. And this is, again, like sometimes for elective surgery, we have used plasma exchange 1 to 2 days before, or like IVIG for thymectomy within 10 days, but no later than 2 weeks. So basically, it can be challenging going to the ER for patients, with MG. And the important thing is you are your advocate. You have to communicate with your ER doctor, with your neurologist, and communication is key. And there are a lot of resources on MGA website which you can print out and kind of keep it. And I usually recommend, like to kind of keep like an emergency kit ready with like, certain, whether it's printout, handout, your card, your updated list of medication, everything kind of handy or ready. And in case you need to go to the ER, just pick up that and then you go, and then the ER physician, they have all the records, the printout or what needs to be done and those kind of stuff in there. So that's one thing I would recommend, because yes, when you are in the ER, your symptoms are worse, and you cannot be trying to talk and tell them like every last thing about MG. So yes, it's hard on the patient, but at the same time, if there is information available handy for the ER physicians, or for neurologists, then it'll be easier, and they can get things started much quickly, and initiate the appropriate treatment. And that concludes my talk. And any questions?
Excellent talk. Please submit your questions to Poll Everywhere. We'll continue to answer them. Dr. Shroff, I wanted you, if you feel comfortable, how would you advise someone who travels out of the country, or even within the country but away from home? What would be your advice to prepare in that respect? Is there any especially international travel, is there anything you can advise?
Mainly, like I would recommend, depending on your length of stay, always take like extra medication with you. Do not, forget your medication. That's important, because even, again, every day can vary. If there is a day you have done more and you need that extra pyridostigmine or mestinon, then you have with you. And also, like I mentioned, like the emergency kit, I would say like a traveling kit also, like where, it has, thing about MG, like who your neurologist is and who to contact. And even if it is, international or within, US you travel, it's good to have those things to carry with you, because in case your symptom is slurred speech, and you cannot communicate with the person, there is a document saying this is what you have, these are the treatment you are on, and in case you need surgery, then these are the things to be done. And like if even like a printout for like recommendation for anesthesiologist on breathing wise, these are the things need to be checked. So if those things are handy and you can take it with you, then anybody or any physician can read that and kind of at least help or get things started and get a neurologist on board if need be. Yeah.
Thank you. That was an excellent discussion. Lots of good pointers, even once you're admitted. Thank you so very much. Okay.
Thank you.
So our next speaker is myself at 1:15, but I figured that we take this extra 15 minutes for our attendees to go get a drink of water, go use the bathroom, do whatever, and then I will come back at 1:15 Central Standard Time to begin my talk, and then we'll conclude this session with a panel discussion or a group discussion about the impact of COVID and your disease. Okay, we'll see you back at 1:15. Thank you. So it's my pleasure to give this talk on our advances in treatment. And if they could put up the slides for my talk, thank you so much. This is a wonderful decade, and 2 decades actually, because we have seen an explosion of newly FDA-approved treatments for many diseases, not only in neurology, but in neurology, and also including myasthenia gravis. And I think that we're going to see a couple more FDA-approved treatments for myasthenia in the next couple of years and then thereafter. And we're already seeing the impact of at least one of these new FDA-approved treatments in terms of improving life for many of our patients. So Marie Curie, the famous scientist, was quoted as saying, "Nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less." And I think that's where we are as we're understanding this disease and what causes it, and we're able to target therapies or create therapies for different patients and with different types of presentations. I think we're less anxious about it. So I hope that you leave this conference feeling more equipped, more knowledgeable, and less fearful. So this is a high-powered, magnified picture microscopically of a neuromuscular junction, which Dr. Schroff, Dr. Anderson have already sort of gone into great detail about. And this on the left is normal. So this is the end of the nerve, and within that are vesicles or sacs of chemical called acetylcholine. And when that nerve is excited, it releases that chemical into this space very close to the muscle membrane. And you see here the muscle membrane is crests, hills, and valleys, and the black stain are just thousands upon thousands of acetylcholine receptors, so that when we move, we have enough receptors, enough ability to activate our muscles, and we shouldn't fatigue because this is normal. However, on the right is a magnified picture of a nerve muscle junction in a patient with myasthenia gravis. And the reason why I show this picture is it shows that everything we've discussed, at the end of the day, this is a destructive process and explains why our patients fatigue. This is the nerve, end of the nerve, the sacs here or vesicles filled with acetylcholine, about the same. But when you look at the muscle, it is far different. It doesn't have this wonderful up and down landscape. And the dark stain, which should be where the acetylcholine receptors are, you have very little staining. And that explains why our patients fatigue, because the muscle lacks the receptors to respond to the chemical, to activate and contract. And Dr. Schroff did an excellent job. Dr. Anderson talked a little bit about the history of myasthenia, some of the therapies. I won't spend as much time, but I just wanted to talk about how far we've come. From the earliest thymectomies, where they discovered when they would take out the thyroid in patients with Graves' disease, they would take out a little bit of the thymus, and they would note that these patients did better, and some of their neurologic weakness got better as well. They used to do hemodialysis, such as what you would do for a kidney renal dialysis patient. They would drain the lymphatics. But it wasn't until the onset of critical care medicine, ICUs, MASH units from the Korean War, that we really made a dent in saving people with acute conditions, including myasthenia gravis. And so now we have greater than 10 to 15 different treatments for myasthenia gravis. This is a long list. Dr. Schroff and Dr. Anderson did a great job going over these treatments. I've listed them out. These are standard of care. This is what we're using in our arsenal today. So out of all of these, the only one that is targeted just for symptoms and not the immune system is pyridostigmine or mestinone. All this does is it prevents that acetylcholine, that chemical that is released from the nerve, from being degraded. So it stays around a little bit longer, and so the muscle can compensate. But it's not enough often as patients progress with their disease. They end up taking more and more trying to get the same improvement. Now, those medicines which you have listed here, prednisone, azathioprine, Imuran, cyclosporin, or Sandoimmune, or Neoral, mycophenolate, or Cellcept, these drugs suppress the immune system through a variety of different ways. Some are pills, which take months to become effective. Some are immediate, such as tacrolimus, rituximab. We'll talk about Soliris. And the last three are treatments or approach to therapy, which really doesn't necessarily suppress the immune system, but changes it, makes it less aggressive and more calmed down. And that even includes the role of taking the thymus out in patients with acetylcholine receptor positive MG. We see that the number of those aggressive immune cells actually decreases over time, and they have typically a more stable, less aggressive disease. And so this is a diagram showing the impact. What you see here is this on the top going up and down is the percentage of patients who died from the early 1900s to close to this decade. And you see that in the early 1900s, the mortality rate, or the number of people who died from what was felt to be MG, was quite high. And it's gone down significantly to about 5 to 8% today because of all of these treatments that have been employed. And this graph, of course, is survival, those who are living with it. And so we've made great advances in terms of treating myasthenia. Myasthenia gravis, for the most part, is a treatable disease. There is a percentage of patients, 5 to 8%, that so far, no matter what we do, they have a very brittle disease or other diseases which complicate it and put them at risk for succumbing to this disease. And so we're always working to make this number as low as possible. And so Dr. Schroff showed a much more fuller timeline for treatments. I've sort of depopulated it. And so this is from 1900 to 2000 up to where we are today. And you see the number of treatments, even the use of iron lungs in the 1930s, ventilators in the 1950s, 55s, and then the use of immune suppression or immune modification in the 70s, 80s, all the way to today. So before we talk about treatments directed at the immune system, I think it's important for you as the patient and your families to really understand what is the immune system doing. And let me just say the immune system is a very complicated system. It has many different aspects to it. It repeats itself. It's very dynamic, and it has to be because we live in an environment where we're always at risk for infection or trauma, cancers, things like that. And the immune system is a group of organs and cells that protect you from these diseases. Dr. Schroff mentioned this in her talk yesterday with our health professionals, which is the role of immune tolerance. And what that is your immune system and mine is created or developed to protect us from things that should not be in our bodies. Bacteria, virus, cancer. But immune tolerance prevents the immune system from attacking what should be in your body, your own cells, your own proteins. So your immune system should be smart enough and strong enough to fight the infection without attacking itself. And that's immune tolerance. I love this quote by Albert Einstein. If you can't explain it simply, you don't understand it well enough. So I am going to try to explain this immune system in a way I tell all my patients that this is how I understand the immune system. So I hope you feel the exact same way. I compare our immune system to the military, the United States military. So the immune system is equivalent to all the branches of the military, the Army, Air Force, Marines, Navy, National Guard, either protecting our boundaries on the outside in foreign lands or inside, or actually attacking and defending us from invaders. And it has a primary defense and a secondary defense. And your immune system is very much the same. And so it maintains the safety and the health of the system, the nation and its territories. If we use that analogy, it monitors, guards, defends, attacks foreign threats, viruses, bacteria, domestic threats, cancer. And it also has different branches, just like our military, that have overlapping function, but also each branch has its own distinct and unique function. And this is our branches right now of our United States military. Thank you for those who've served and who are serving our country. So this is a busy slide, and I don't want you to get confused, but basically these are the major players in our immune system. Number one, we have stem cells. That's a very common, popular word today. This is a cell that has the potential to become anything in the body. And those stem cells are in the bone marrow, but the stem cells that are committed to becoming immune cells become early B cell and an early T cell. You'll hear these terms before. So these are the two major white blood cells of our blood. They're not the only ones, but they're the two major ones. And the stem cells turn into early B and T cells, and they go to immune organs. The bone marrow is a major immune organ, and the thymus gland is another primary immune organ located right underneath the thymus. And it's in these areas where these cells mature and develop. Just like children, they're naive, they're immature, but then they're exposed to the things in our body that are natural. But as we grow up and we're children and we get infections and we get the mumps and the measles, our body and our immune system gets exposed to these foreign things with the hope that these cells will mature to be able to populate the rest of the body, your spleen, your lymph nodes, and your skin, to make sure that if you are attacked, it knows how to fight. So this is a really cute cartoon because that process of maturation and learning who the enemy is, but also knowing what not to attack, I describe as the immune boot camp, the immune boot camp. So here is the bone marrow, and he's talking to these baby stem cells, these new enlisted fighters, and they've been recruited, and they're going to go through a boot camp under the training of the thymus gland, general thymus, who will shape these cells into elite fighters. They'll gain a new identity, and they will become killing machines for the immune system. This is your T cell squad. They're smart, they're strong, and they should be able to detect and take out what's foreign without affecting the homeland. That's normal immunity. So we're going to spend a little time. So normally, you have a foreign protein, whether it's bacteria, virus, cancer, we'll call that AG, antigen. And then you have a sentinel, a guard, looking for something invading. We call this an APC. It takes a little piece of it, it looks at it, it studies it, and it takes it to the general and says, we have foreigners in our land. And so this general identifies the foreign material, develops a battle plan, and it actually recruits other T cells that bring in more forces. They bring in the B cells, which are the other major white cell. And based on this foreign material, the B cell can develop the weapons, the antibodies, specific for that foreign material. These antibodies are specific for the foreign material, the bacteria, the virus, what have you, and it also enlists these specific missiles or scud bombs that attach and blow it up. That's normal. Sometimes it enlists snipers, special forces. We call these killer T cells. They don't need to recruit anybody. They just take out the foreign material all by itself. This is normal immunity. And what's also important is that these cells keep a memory. They remember this foreign material, this infection. So if we're ever attacked again, they know exactly how to mount the response quickly. And then after a while, we have to calm down. We can't stay in the attack mode all the time. So there's another T cell that regulates this and calms it down so that we're not always in the attack mode. We're not always inflamed. So in myasthenia gravis, the problem is that these T cells, during the basic training in the thymus gland, is not accurate. It's not good training. They're released for duty without the ability to tell self from non-self. These T cells, for whatever reason, and we can talk about that later, there's a reason why we think the T cells feel or identify the acetylcholine receptor, the MuSK receptor, and other proteins which Dr. Schroff mentioned earlier in her talk, which are very important for muscle function. They see these proteins as foreign, as invaders that need to be taken out. Why some people develop these diseases and why others don't, we don't know. We know that there is a genetic predisposition. Often we see autoimmune diseases in families. There may be some environmental causes, but myasthenia gravis is one of several autoimmune diseases where the immune system has lost the ability to tell self from non-self. And so as Dr. Schroff mentioned, the thymus gland is abnormally activated in the majority of myasthenia gravis patients, those who have acetylcholine receptor positive myasthenia. We don't see the same thymus pathology in patients with MuSK, although the immune system is activated and is not normal in that respect, but the thymus gland may not be the primary place where the problem is happening. And so this is a patient, this is the CAT scan, this is the lung, this is the heart arteries, the aorta, and this is the heart. But this shadow here is a enlarged thymus gland. And normally, once we become adults, there should be nothing there. Children have this normally because they're developing. But once we reach adulthood, it should have done its job. This is someone who actually has not just an enlarged one, but an actual tumor. And we see this mostly in patients over 60. The majority are benign, but as Dr. Schroff mentioned in one of her talks, if this is seen in either situation, they should come out. And this is what it looks like under a microscope. This area, the center, is enlarged, very active proliferation, and it's releasing T cells which are not smart. So if we take that same illustration in a myasthenia gravis patient, you have a T cell which has decided that the MuSK receptor or the acetylcholine receptor is abnormal. It becomes activated and it tells the B cell, okay, I need you to get these proteins, create antibodies, and attack. Whether that's MuSK or it creates antibodies against the acetylcholine receptor and recruits these missiles called complement to attach and blow it up. And what we see is the T cell, the regulatory cell that should be available to calm this process down, actually in myasthenia gravis patients has been shown to be not as effective. There are less of these in the system to calm this immune attack down. So this is a wonderful sort of basic illustration that has been used for our patients because I think it's very important for you to see in a basic way what we mean. Again, this is a cartoon illustration of the nerve, the chemical, the acetylcholine, normally released and interacts with the acetylcholine receptor. The MuSK receptor is important for keeping this organization, keeping the receptors at the top, keeping the muscle in an undulating process. And then you have acetylcholinesterase, a little garbage disposal protein, which gets rid of all of this excess acetylcholine. This is normal, okay? And as Dr. Schroff mentioned, there are a number of proteins that are very important for this function, which we now have identified antibodies against in myasthenia gravis patients, some of which we know are causing disease, others we're not so sure. And this is that high-powered picture showing the normal anatomy. When we get to acetylcholine receptor positive patients, the most common type, because the B cells, the immune system has created these antibodies and the complement, the Scud missile type proteins which destroy, you can see that the muscle cartoon doesn't show the ups and downs of the muscle. You have fewer acetylcholine receptors. Even the space between the nerve and the muscle is increased, and so our patients get this destructive, altered appearance, and they become weak. And so this is where I'll start my talk about treatments. I won't go into much detail about the standard therapy because Dr. Schroff and Dr. Anderson have done a wonderful job. I'll touch base again on the thymectomy trial. This was a landmark international study which was done across many nations. It took quite a long time because 2 of the leading investigators unfortunately passed away unexpectedly. But this looked at 126 patients who were either randomized to be on prednisone alone or to have a thymectomy and prednisone. And it was interesting, the patients would have to show up in the clinic with these scarves on so that the doctors didn't know if they had the surgeries or not. So they were blinded to who had surgery and who did not. And the whole goal was to say, okay, at 1 year, at 3 years, and now we have data from 5 years and out, how did the patients do? Did they have less disability? Were they on as much prednisone? Did they go into the hospital as much versus patients who never had the thymectomy? And the results were very impressive. The disability in patients who had the thymectomy was better. It wasn't as bad than those who just had prednisone. And they saw this at 1 year, 3 years, and have continued to see the long-lasting benefit of a thymectomy in acetylcholine receptor positive patients. The patients over time have less crisis, hospitalizations, but the side effects were about the same. So this was a study that finally proved what we all figured, is that in acetylcholine receptor positive patients, thymectomy improves the outcome of myasthenia. Rarely do we see cure, but we definitely see improvement in the history of the disease over time. And these are pictures that show, so the blue line are the patients. This is a measure of disability. It's called the QMG. And the red line are patients who had the surgery plus prednisone. The blue line is those patients who just had prednisone, and the level of disability was less over time. And this is out 36 months. This is the amount of prednisone they were taking, and you see that patients who had the thymectomy plus prednisone were on lower doses of prednisone over time compared to those who were just treated with prednisone. So Dr. Schroff mentioned this as well. It is important because some of you have asked the question, what about older patients? They really didn't see the same degree of benefit in males, especially compared to females. More females, of course, have the disease younger in age. And they didn't see a significant or as great an effect in patients over 40 and definitely over 60, okay? They also found that patients who had never received prednisone before in the past really didn't show a benefit for thymectomy. So there were still some questions here, but we now know that probably thymectomy is not indicated in an older patient, especially a male patient, unless there's a thymic problem, a tumor that we can detect on CAT scan or MRI. And so this is a busy slide, and I don't want to confuse you. We're going back to the immune system, and that's why I spent so much time sort of describing it to you. So, because the treatments that we are now studying are directed at some of these cells and pathways. So you have that T cell, it's being presented with foreign material. It talks to the B cell. the B cell begins to get activated and create antibodies. And for acetylcholine receptor positive patient, recruits this scud missile protein called complement, which attaches here and destroys the acetylcholine receptors. I also want to point out that these antibodies that are made in our myasthenia gravis patients, and this includes the MuSK-positive patients, as well as probably our seronegative patients who have definite myasthenia gravis, because you too have antibodies that we just can't detect with our standard testing. But those antibodies that are circulating, normally all of our antibodies get recycled. There's a mechanism where they go into a cell, they're cleaned up, and then they're released back into circulation. And so this is also an area to target for therapy, and we'll talk about that, because how do we prevent your antibodies from just recircling back? We take it out with plasmapheresis, we decrease it with IVIG, and then they keep being made and they keep recycling back. So these are our current clinical trials that are ongoing. I'm going to concentrate on, these are the drugs that I'll talk a little bit about in terms of stopping that recycling through a protein called the fetal FCR receptor, which is a receptor on antibodies. And then, of course, there's been a lot of work on those scud missile proteins that I mentioned called complement, which blow up things once they attach. And these are complement inhibitors. And so we'll talk a little bit about that. So a little bit about those scud missile proteins. So when the antibodies attach, they recruit these proteins called complement. Complement is a group of proteins, up to 9 different proteins, that are so important for helping us to not succumb to certain types of infection like bacterial pneumonia, bacterial meningitis. Because what they do is when they're activated, they sort of activate C1, activate C2, activate C3, and once we get to C5, it activates these other proteins, 6, 7, 8, 9, and these proteins come together like a transformer comes together. All these pieces come together in a puzzle, and they make a little pore, a little hole in the cell, the bacteria, and they blow it up. That's what complement should do against bacteria, but unfortunately in myasthenia gravis, when it deposits on the muscles of acetylcholine receptor positive patients, it's doing the same thing. And you see that, C5, and they're all coming together to create this pore. And what we see on high magnification are these punched out holes in the cell causing destruction. And so this is a kind of the same high-powered picture of the neuromuscular junction, and this is in myasthenia gravis patients. But this time, in the top left, we're staining for IgG, or the antibodies. So we know that the antibodies that are attacking myasthenia are there if you look at this area. When you do another stain for that complement, the scud missile type proteins that attach, put a hole in the membrane and cause it to be destroyed, we see that it's also commonly deposited on the muscle side of patients who have acetylcholine receptor positive myasthenia gravis. The reason why I keep making this distinction is that MuSK-positive patients have antibodies. The antibodies, as Dr. Schroff mentioned, are a little different. They're IgG4, and so they don't attract complement. They destroy the membrane, a different mechanism. So this was a study, it's called the REGAIN study, of a complement inhibitor, equitizumab, or Soliris is now its FDA-approved name. And it was a double blind. That means the patient didn't know if they were getting placebo or drug, and the physicians at each site didn't know what this patient was getting. And the whole goal was to say over 26 weeks, Did their activities of daily living, the ability to wash their hair, go to the grocery store, get up from a chair, did that ability improve with equitizumab compared to patients who just got placebo? And they were looking for patients who were acetylcholine receptor positive because those are the patients where complement is part of the problem. They were not looking for patients who were so mild just with ocular disease or so severe in an ICU intubated. They were looking at everyone in between. These were patients who had had the disease for up to 30 years, from 1 year all the way to 30 years. These were patients who were on at least 2 medications already, many of them getting IVIG and plasmapheresis, yet they were still having trouble with their day-to-day living. So this was a very important study because that's where most of our patients dwell. So in this, the patients who entered this study, 90% were on at least 2 immunosuppressive therapies, up to 50% had been hospitalized in their lifetime, up to 20% or more had already had a crisis or knew the experience of being ventilated, and at the time of coming into the study, despite all this, they were still having symptoms. So what is this activities of daily living score? Dr. Schroff and I believe Dr. Anderson mentioned this. This is something that patients fill out. We want to know how you feel. And this was the first study that actually used a patient survey to determine efficacy. Typically in clinical studies, it's what the physician measures. But it's been so important to know what affects your life that now the studies are developed based on the patient-reported outcome. So this is an activities of daily living. It's a 4-point measure looking at talking, chewing, swallowing, breathing, ability to brush your hair or teeth, eyelid drooping, and it's how often this happens in the past 2 to 3 weeks. We give these to our patients in the clinic. You might be very familiar with it. You can download this from the Myasthenia Gravis Foundation of America website or you can Google it, and you can begin to fill this out maybe once a month or right before your doctor's appointment so that you can open up a discussion of, I'm doing okay when you test me, but I'm still having difficulties with these activities in my life. There's also a quality of life measure about how does this impact your quality of life? Are you overwhelmed? Are you depressed? Do you have trouble taking care of your family? Is your occupation affected if you're even able to work? Very important. Now this is a quantitative myasthenia score. It's more of an objective measure. It's done by the doctor, and this is what we've used in the past. We still use it because it is more objective. And so if we go back to the Solaris study, the complement inhibitor, equitizumab, in the study that I was describing earlier, these are the results, looking at activities of daily living. So in the red, these are the patients who were randomized to placebo. The blue line are patients who received equitizumab, the study drug, over 26 weeks. Everyone was blinded. The patient didn't know, the doctors didn't know. So when we measured their activities of daily living, what they reported, you see that within 2 weeks, the treatment group had a marked improvement in their activities of daily living. The placebo group had a placebo response, which is very common to clinical trials, but as time continued, you see that this was a marked difference, that the treatment group had much greater improvement. Then at the end of the study, all patients, even those on placebo, received the drug. And look at this response. They were on placebo here, got the drug, and like the original group, improved dramatically to the point that these lines pretty much overlapped, and we're still monitoring and following these patients. We even noted that patients had minimal manifestations of disease, which means that in their day-to-day living, no one could even tell they had myasthenia gravis. Maybe they had a lid droop at the end of the day. Maybe when the doctor tested them, they were a little weak in the shoulders. But overall, just in their everyday interactions, no one could tell. Minimal manifestations of disease. And what we found is in the placebo group that they went from 14% with minimal symptoms to once they got the drug, up to 130 weeks later, 52% had minimal symptoms that could be detected. In the treatment group that got the drug from the very beginning and also at 130 weeks, 25% had minimal symptoms at the end of the first part of the study. We're still monitoring them, and greater than 60% have minimal manifestations of symptoms. In fact, the number of times patients had to come into the hospital due to exacerbations dropped from before the study at 70 to 100 rate calculations to only 13 to 17 events at 130 weeks. So quite impressive. And so this is just a graph saying the same thing. I won't spend too much time. Just know that not only did their activities of daily living improve, but the number of times they had a crisis or an exacerbation or required hospitalization also significantly improved. And so in terms of side effects, very well tolerated. The side effect profile, nothing was severe, equal between both groups. A couple of people did pass away after this initial study, not related to Soliris, related to other things. All patients during the study and even now, because equitizumab or Soliris has been FDA approved for treatment, must be vaccinated against Neisseria meningitis, a very dangerous and fatal bacterial meningitis. And it requires vaccinations with several types. There are 2 types of vaccines, often separated by 2 months. We can start treatment after the first 2 sets of vaccinations, but you must complete it to continue to take or start this medicine. So there's another complement inhibitor. It's called zilucoplan. It works very similarly, although it's a different formulation than IV Soliris. And this time they looked at, and this is a phase 2. So it's not the large amount of patients. It's really the clinical study before the big study that leads to FDA approval. It's like the test study to make sure that there seems to be benefit, the right dose that gives the benefit without significant side effects. And so they looked at this complement inhibitor at 3 doses, 0.1, 0.3, or placebo, and they were looking at the doctor measure, the more objective measure after 12 weeks. So this is a very short study, small patients, only 44. And again, these patients are acetylcholine receptor positive because complement is part of that process. 50 to 70% were already on IVIG, and over 80%, again, were already on treatment and were still symptomatic. And if you look, this is a smaller sample of patients. It's a phase 2, not phase 3. We're doing the phase 3 now. Our site participated. And again, you see that in the placebo arm, the blue arm, you get a placebo response. And this red arm, which is the higher dose, had a greater response that really became more evident as they approached the 12 weeks. Similar to the other study, at the end of the study, everyone got the drug, and you saw this improvement again, which continues. And they also looked at that patient-reported survey, ADL, what the patient reports. And again, you see that both have a response, placebo and drug, but the people who received the drug had a much greater improvement in their reported activities of daily living. And then everyone got the drug, and you see a similar improvement. So this is very encouraging. The phase 3 study is active right now, and hopefully we'll have another FDA-approved complement inhibitor to add to the arsenal. Again, we talked about minimal manifestations of symptoms, same thing, and we see a dose response that the patients who were able to have minimal symptoms at the end of the study, we saw that middle dose was better than placebo, but the higher dose was even better than the middle dose. So still very encouraging. So I'm going to end my talk by talking about those IgG recycling drugs. So I said that in all types of MG, antibodies are created which direct the immune attack. Acetylcholine receptor involves complement, which attaches, punches holes, and destroys the muscle. And these new complement inhibitors appear to be effective, and we're identifying more. Not all myasthenia gravis patients have that type of antibody. Some have MuSK, which has nothing to do with complement, And some, we can't even detect antibodies, so we're not sure if they have them or if it's a kind that we can't detect, so we don't know. So we need a drug that can affect all antibodies, whether there's complement or not. So I talked about that cycling. So normally, and bear with me, you have these antibodies circulating in the blood. So if you look at the top left, you see these little Ys here with the red tips. These are antibodies. Let's say they're myasthenia gravis antibodies. And normally they get taken into a cell, and there are these receptors here, these little yellow proteins here. This is a receptor called the FCR receptor, which anchors these antibodies, puts them into a nice little cell, a nice little bag here, and binds them. And they come through, but the binding is not that strong, and the majority of these become loose as the changes in here, changes in this little compartment change, and the antibodies become loose from this protein, and they're released back out to cause more damage. A few of them get degraded. So how do we direct this where all of them or the majority of them get degraded versus being released back? This is where these new treatments are important, because if we can block binding to this anchoring protein and bind it up stronger with something else, then we can prevent it from coming back out. And that's exactly what these new FcRn receptor-mediated drugs are meant to do. So the antibody anchors to this FcRn protein, which places it in this compartment in the cell, but the drug binds them too in a competitive way. But this drug has been made to bind even stronger than the natural FcRn receptor. So it competes with it. And by competing with it, it holds on to those myasthenia antibodies stronger so that they can't be released back into your blood. They're designated for destruction, and so we decrease the number of circulating antibodies in the blood for all antibodies for all MG patients. And so quickly, this was a study. This was 167 patients, with both, the majority of which had acetylcholine receptor, but there were about 20% that were not acetylcholine receptor positive, so they did look at patients who had MuSK or were seronegative. Again, these patients were symptomatic. They were already on treatments. They gave them 4 weekly infusions. And what's interesting about this drug is that after that, the number of times they repeated it was only dependent if the patient became worse. So it was very individualized. So if the patient was stable, their exam was stable, their measures were stable, they didn't get another dose. They would only be dosed if they showed decline. And so that's important too for specific individualized treatment. And so what it showed was that patients who were on this FcRn antagonist or blocker, it's called efgartigimod, they had a clinically meaningful improvement in function and strength. Again, we have the patient-reported survey, activities of daily living, and 67.7% of the treated patients had greater than a 2-point improvement over 4 weeks of the first cycle. When you looked at the physician measure, which is more objective, it was also 63.1% with 3 points or greater improvement. This is with the first cycle, the first treatment before repeating it. And then we talked about, what about minimal manifestations of disease? Again, how well does this drug leave the patient with almost undetectable symptoms except when you ask them or when a doctor tests them? And even after the first cycle, up to 40% of treated patients reach this peak. Again, this is very encouraging, and this will likely be the next, very soon, FDA-approved drug in myasthenia once phase 3 is completed. So we talked about the first cycle. Some patients didn't respond after the first cycle. But I think it's also encouraging to know that when they repeated the treatment again as a second cycle, 40% of patients responded. It's not shown here, but 40% of the patients who initially didn't respond responded after the second cycle. And then you see the change in the ADL improved from the first cycle to baseline, and then after the second cycle, you see an even greater improvement because the late responders finally responded here. So first cycle, a great number, but an even greater number with the second cycle because the late responders finally responded. I hope that makes sense. And then also, to prove that it's working, because it prevents the antibodies from being released back into the system to do damage, we can also document that the antibodies, as dictated or shown by the green circles and the dark circles, are decreased. This is for the acetylcholine receptor antibodies are decreased in the blue, but also in general, all the antibodies are decreased in regards to the treatment. So we know that we're doing this by decreasing the number of those attack antibodies in your system. And this is just another one. I won't go into much detail. It's looking at another FcR receptor modulator, looking at 4 doses, same types of patients, and already we're seeing in an early phase 2 study improvement in the activities of daily living here. This is placebo, this is one dosing, another dosing regimen, a higher dosing regimen at day 29, and then by day 57, we're seeing some variability, but there's still signal for improvement. So this study is ongoing, and we hope to hear something by the end of the year or the beginning of next year. So I think that's a lot to digest, and but I think if anything, we should all be very hopeful about the directions that we're going in terms of treatments for myasthenia gravis. The more we're learning about this disease, the immune system, it's a military analogy. I think that works very well for me. I hope it works for you. But what it does is it helps you to identify why these drugs are being developed and how they're targeting the disease. And so any more future advances will be based on identifying these targets. There's always going to be some issue with cost, insurance authorization. We're learning how to fight those battles, and I think we're doing a great job. But what's exciting is that how we're developing therapies that will be specified for you as an individual patient. So I'll stop there, and I am happy to take any questions that may be in the poll everywhere or anything. We also had some questions from Dr. Schroff's talk. Okay, so just these four. All right, I'm going to answer the topics from my talk, and then I'm going to bring Dr. Schroff to answer her topics, okay? So let's see here. Could you please comment on the side effect profile of immune suppression and how immune suppression might change the risk factors for someone for infection and cancer? I think we all could answer that, but I'll go ahead and take it. You know, the thing about our treatments is we have to weigh the benefit and the risk between the treatment and the risks that it causes. So these are immunosuppressants, which means that your immune system has to be weakened in order to get your disease under control. Most of the standard therapies, steroids, Imuran, or Cellcept, are not very specific. They affect multiple cells, T and B cells. Prednisone affects many things. And so the suppression is more diffuse. And but even with the monoclonal antibodies or the more specified targets, your immune system is weakened, and it does put you at risk for certain infections, even certain skin infections and skin cancer, as we tell our patients on Cellcept. So we have to balance that. And so what we do is we talk to our patients about staying up with their annual or biannual screening with their primary care, having their skin checked if they're at risk for cancer, having their colonoscopy, their mammography, Avoiding sick contacts. We've already talked about the importance of vaccinations to lower your risk of many of these common infections that get our patients into trouble, and advocating for yourself and communicating. So we weigh the benefit. And at times, we'll check your immune status. We'll check if you've been exposed to something before we give the treatment. It requires coordination and communication. So the time between the cycles of efgartigimod. So the initial cycle was 1 weekly infusion for 4 weeks, and then they determined the next cycle based on the change in the course of the patient. So whether the ADL went down or it didn't progress another 2 points, or there were clinical symptoms. So if this is an FDA-approved drug, this interval between the cycles will vary based on the patients. I think that at 8 weeks, though, it's going to require an evaluation by the doctor just to make sure, even if the patient doesn't feel any different, because there may be some subtle changes. So we're going to learn that as we go. And I think I answered that with this, I answered this question, hopefully. The other question is, do any new treatments cause remission? We're still monitoring that. I believe that we all, in the myasthenia gravis field, have patients who are on Soliris. But even in the prior treatments, we've been able to get remission in some patients, so it's even possible with older treatments. But I think there are physicians, maybe 1 or 2 of us here, that have patients who we would say are on a medicine-induced, treatment-induced remission. It's important to know that remission does not always mean I'm not on any medication. In fact, many of the patients who do reach remission do so because they're on medicine and or Mestinon. And so I think we are seeing those patients with Soliris at least. We'll see with the other medicines. All right, so I'm going to ask Dr. Schroff to come back up. She had some questions from her last session. We're going to segue into our panel discussion. So once I'll let you answer, and I'll feed them to you. I'll feed them to you. Come, or you want to feed them to yourself? Okay, I'll let you answer them. You pick them up. Yeah.
So this was one of the questions. If they have minimal manifestation of the disease, only some ocular problems, LRP4 positive but negative on everything else, what should they do? So again, if it's when it's minimal manifestation of disease, meaning only intermittent every now and then, and if you respond to just pyridostigmine or Mestinon, then I mean, that should be good enough. Unless, like you develop persistent symptoms, then you need more immunosuppressant or immunomodulatory therapy. Then we might have to initiate that. So that's kind of like, that's why it's important to follow up with your neurologist to see how this condition behaves in you. So this was another question where patient has all the physical indicators of MG, yet they respond to Mestinon, they have all the symptoms, negative SFG, single fiber EMG. Since it's considered gold standard of diagnosis, will it dismiss and will dismiss positive titers and classic symptoms? So if an antibody is positive and you have symptoms, even if SF-EMG comes back negative, then we would still treat. Again, on the other hand, if you have all the antibody positive, SFE-EMG is also all the antibody negative, SFE-EMG is also negative, but you have classic symptoms, then even then we would give a trial of treatment to see how you would respond. So that's what I would recommend. So if the thymus is causing MG, does that show up in blood test or does it have to be imaged? So there is no blood test for thymus gland. It has to be imaged, either CT or MRI has to be done to look for thymus pathology.
Can you bring the clicker and Okay. Can you hear me? So we're going to switch to our panel discussion. So thank you. We're going to go ahead and transition to our COVID panel for the next 15 minutes. And we already had some questions in the chat about COVID, and we'll post them after our presentation. So if we could just put up the few COVID slides. We've put together just a little bit of reminder information about COVID and recommendations. Okay. Could you advance the slide, please? Thank you. So what we know from the COVID pandemic is that masking, social distancing, and washing our hands are key elements to decreasing spread and do benefit by mitigating the spread of COVID. We've seen that. And we now have vaccinations, both mRNA and DNA vaccines that have been approved to prevent infections that are now, they've been deployed. And the thing about viruses is they do mutate, so variants are expected. That's not a new thing. And now we have been dealing with the Delta variant, which is now slowly showing a decline in the past month, which appeared to spread more quickly and maybe more severely. And although it's a different strain or a different variant, the vaccines so far appear to be covering it as well. So our susceptible populations, this is all on the CDC. This is not new to most of us. Being of older age in terms of susceptibility to a severe infection, even requiring hospitalization or acute care. Chronic medical conditions, we've seen that, whether it's liver, heart, kidney, diabetes, lung, or cancer, and that includes an immunocompromised state, whether that's cancer or cancer treatment or chemotherapy treatment, similar to what many of our patients are receiving. Living in high-density communities or space, such as nursing homes, college campuses, and obviously we've seen some research on the role of genetics and blood type. I'm going to let Dr. Schroff take this.
So there is a international MG working group which was formed in May of 2020. Patients on existing therapies for MG and LEMS were included in this treatment, in this working group. They were advised not to stop any existing medication unless specifically discussed or approved by their neurologist or healthcare provider. There was no scientific evidence to suggest that symptomatic therapies like pyridostigmine or 3,4-DAP in LEMS patient increases the risk of infection and should not be discontinued. There is currently no evidence to suggest that IVIG or plasma exchange carry any additional risk of contracting COVID-19 infection. There is also currently no evidence to support the targeted C5 complement inhibition using equitizumab increases the susceptibility to COVID infection or its outcome. So CARE-MG is COVID-19 associated risks and effects in myasthenia gravis. It's an international registry. It's in joint effort from International MG and COVID-19 Working Group and neurologists. So it's still open pretty much to any worldwide neurologist can submit their MG case who have had COVID. It takes about 10 minutes to enter their case with all the information. They did an interim analysis in October of 2020, at which time they had 91 patients who were entered in that registry. The preliminary data basically show that patients with MG who are infected with the SARS-CoV-2 are frequently admitted to the hospital. They do have disease exacerbation, and they have a higher mortality than the general population with COVID. And again, it's an ongoing study. It was an interim analysis. We're still, waiting to see like what the outcome of COVID in MG patients is going to be. So there's also a new paper which came out. This is Myasthenia Gravis and COVID-19 clinical characteristics and outcome. So here, basically the conclusion of this paper was MG patients who were hospitalized for COVID-19 may have more severe course than other hospitalized patients, probably because of bulbar muscle involvement. They already have like respiratory muscle weakness. And on top of that, when COVID-19 affects the lung tissue itself, it's an added burden on the breathing. So the baseline immunosuppressive therapy is not necessarily associated with worse outcome in these patients. Thus, its maintenance is advised. Furthermore, the immunotherapy for MG exacerbation seem to be safe and must be considered in this context, and that's why we don't recommend any of our MG patients to get off of immunotherapy despite being in the midst of pandemic.
All right, so there are the current vaccinations and that we're familiar with here. So the first is Pfizer. So this is given in 2 doses that separated by, I believe it's 21 days. And then there is now a booster dose. And the timing of that booster dose typically depends on immunocompromised status. But usually that's given several weeks after they've received the second dose of the Pfizer vaccine. And then the Moderna is the other type of vaccination, also given in 2 doses, and I believe that they're separated by 28 days for this one. And then the Johnson & Johnson or Janssen vaccination is just given in 1 dose. And so it is a common question as to for our patients in regards to the timing of the vaccinations. And so this goes for the COVID-19 vaccination as well as flu vaccinations that are now present as well. And so if you get for your IVIG, we typically recommend kind of at that midway point. So for example, if you get your IVIG every 4 weeks, then about 2 weeks after or 2 weeks before your next infusion is when we recommend getting the vaccination. And then for rituximab, we recommend usually getting it about 6 weeks before your infusion, and then the second vaccine about 4 weeks before the next treatment. And so vaccination is recommended for myasthenia gravis patients due to the issues with immune suppression and the issues with lung weakness. And the booster shot 6 months later is recommended for those greater than 50 or older and or other risks. And if you're taking certain immunosuppressant medications such as prednisone, azathioprine, mycophenolate, then you will not be fully protected even if may not be fully protected even if you are fully vaccinated, but it is important that we know the vaccination does provide additional level of protection. And I think that the last, oh, okay. And so we have just a quote here from the CDC, which says that no imbalances are observed in the occurrence of symptoms consistent with autoimmune conditions or inflammatory disorders in clinical trial participants who received COVID-19 vaccine compared to placebo. People with autoimmune conditions may receive any FDA-authorized COVID-19 vaccine. So that was the last slide there. So
Thank you. Thank you so much. So we'll open it up to poll everywhere, or if you can submit questions to the live chat and they can direct those to us. I will pull up, if we can put up the poll everywhere screen. I will post one of the questions that we received earlier today. And I would ask Dr. Schroff if you feel comfortable taking that, please.
So basically here it says, discuss the MG exacerbation following second and third Moderna vaccination, significantly increased muscle weakness, difficulty walking, double vision. So we have heard few patients who did notice worsening of their MG symptoms with the vaccine or with the booster vaccines. So so this is the way I would like to explain. So we know certain triggers for MG exacerbation or even crisis is infection. So COVID-19 active infection in itself can also cause much severe exacerbation, affect the lung tissue, and patients can end up with respiratory failure. And we have seen this in healthy patients, in patients who have some comorbidities, who get severely sick and are in ICU intubated, end up with tracheostomy, ventilator dependence. These are in patients not with, non-MG patients. So if an MG patient gets COVID, so again, the risk is high and can end up with the same complications as well. So it's which risk is better? I don't know how to frame that, like the risk of active infection versus the side effects of the vaccine, which can at least reduce the severity of the infection. Yes, it can cause some symptoms to flare up, but reduce the severity of the symptoms. So that's probably, it's kind of like a benefit risk, which we kind of have to weigh and then decide on what is best, to actually get active infection and take that risk, or to take the vaccine and take the risk of, the MG symptoms getting temporarily flare and then kind of settle down.
And I would add to that, I agree with you. And to be honest with you, any vaccination runs the risk of worsening myasthenia gravis because it does promote your immune to respond. And so there is a degree of inflammation, although it's not the infection per se. So we can see that even with a few patients who get the flu vaccine or the shingles vaccine. But, and so again, I agree with what Dr. Schroff has said, that the risk of the infection far outweighs the risk of the vaccine. There was a question that came in earlier, it's not in the chat anymore, and it was about getting tested for COVID antibodies. And I was gonna ask Dr. Schroff if she felt comfortable talking about that. The question was, should we get tested for COVID antibodies in terms of the booster? I was told that the antibodies are only for those who had actual infection. They don't measure the vaccine. So they're asking about that. Or Dr. Anderson or Dr. Schroff, whoever, I'm sorry.
Go ahead, you can start first.
So, we see the antibody titers, when we get the result. So what does the titer mean to us? Like say if 1:50 is that protective, or is 1:100 is protective, or is 1:400 protective? So we don't have that, kind of data with us. Okay, what level or what titer of COVID antibodies is actually protective, and I don't and we can say like, okay, we don't need a booster, or like we are protected. And the next question is, how long is that titer gonna stay? Like is that something temporary and it starts to reduce, versus is that titer is long lasting? If I check now and 6 months later, is it still gonna be high enough to protect me? Or is that titer, yes, I check it today and this is the titer, and then if I check it 6 months later, is it dropping? So we don't have like all the answers to that question right now. So in that regards, like it is recommended to get the booster just to make sure that our immune system is constantly making the antibodies to protect us against the COVID infection. And I'm gonna let Dr. Anderson, add.
No, I completely agree. I think that what we don't know exactly when we're talking about these different antibodies and the titer testing, exactly what that means in regards to our immunity with COVID-19, but we know that patients who receive the vaccine, before all of these even titers were available, that they do better and they're less likely to contract the infection. And so that is really what we're looking at in making sure that we know that we have infections that are vaccine preventable. And so we still encourage it, and following titers or antibody levels may not be the most effective way in understanding that level of immunity, but it's still important in regards to ongoing care. And so I think, as Dr. Schroff mentioned, we still need to get some more data in regards to how that correlates, but we know that receiving the vaccine and the booster, if it's available, is important.
And I would just add to that, a lot of people, including healthcare professionals, are monitoring their antibody levels. But we've all had patients who had the vaccine, and either a few weeks later or a month later, they get antibody tested and they don't have detectable antibodies, or they have very little. And as Dr. Anderson and Dr. Schroff suggested, number one, older people don't mount as strong an antibody response. And if you're on immune suppressives, it's possible that you won't mount as much of an antibody response. But I will just confirm with what Dr. Anderson said, that antibody level doesn't necessarily reflect your immune protection, because it's just the antibodies. And you also have those cells that make the antibodies that have memory. And that's not what we're measuring in the blood. So there can still be protection even if your antibodies are low, and even not detectable. It doesn't mean that the cells that responded to the vaccine don't have memory and are not ready to attack when exposed. So we have one more sets of questions, and they're about the same thing, to be honest with you. So we talked about when to dose IVIG and Rituxan, but these are patients whose treatment schedules are different. Some are getting subcutaneous IG weekly or IVIG more frequently, and even Plex, and then there's about the other vaccinations. So I'm just going to let you guys sort of answer, and we'll all pitch in together.
So let's see. So the first one, weekly IVIG infusions are worth getting any of the vaccinations. So I believe the kind of the overall consensus here and theme is that yes, it's worth getting the vaccinations. As kind of mentioned during the presentation, ideally we would like it to be given in the kind of off time between the infusions, but if you don't have kind of an off week or 2 weeks, then waiting at least a couple of days or a few days after your IVIG infusion would probably be the best alternative there. Let's see, vaccination schedule for sub-Q, and again, it kind of follows the kind of the same. Just kind of give a little bit of a space between giving the when you get the sub-Q IG injection to when you're getting your vaccination. And again, for the last one, recommendations on when to get vaccinated if getting Plex routinely. So I'm not sure what the schedule is for the routine plex, but it would still follow this kind of the same principle or protocol, and that whenever your off week or weeks are between your sessions, to get the vaccination during that time.
And I would just add to that, so it's not that getting IVIG or Plex treatment is going to make the vaccination or effect of vaccine worthless. There will still be effect of the vaccine. It might not be like 100% effect, but there is still beneficial effect of the vaccine. So it's definitely worth getting it no matter what treatment you are on. Yeah.
Excellent. And it also encourages those about the booster too, for that same reason, even more reason to get a booster shot. So we're at the end of our program. We want to be timely. I want to thank Dr. Anderson and Dr. Schroff and Dr. Michelle Cowell, who could not return for the panel discussion, for giving excellent talks. This session, as well as yesterday's, will be available with a link with access to all of our PowerPoint presentations to look at your discretion and use. We want you to use the information, and we definitely want your feedback, so please fill out the evaluations and surveys so that we can make this program the best that it is for you and other healthcare professionals. If we could put the poll everywhere back up, I wanted to put one last comment from the poll everywhere in. I thought it was very appropriate, and this is why we do what we do. We actually have 2 more questions, but we'll answer that afterwards. So this is from one of our attendees. So ma'am or sir, thank you so much. It says, thank you so much for your responses. This was a very informative conference, which I've been watching attached to a BiPAP in the ICU. Landed here after a thymectomy, sparked an exacerbation. Thank you again for all the work you are doing for your patients. And I just wanted, that particular comment really sums up why we're doing what we're doing, because we want you as the patient to be armed with education and resources to make sure that your care is the best that it can be, to ask the right questions, and to advocate for yourself no matter what hospital or clinic setting you have to enter into. So we hope that we've done that today. So this concludes our 12th annual Health Professionals and today our Patient Education Conference. We wish you all the best. Please give us feedback, and we will see you next year. Thank you.